Yeah, ma'am, we are on live, ma'am. So, very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's international webinar on POP in midlife. So, I would like to thank Indian Menopause Society for giving us an opportunity to take over this webinar. I welcome all the chief guests, guest of honor, speakers, and the participants. And now I hand over the session to Dr. Padma, ma'am, to take it forward.
A very warm hello. A
Yes,
very
ma'am.
warm good evening to all ladies and gentlemen. We have gathered here today for the Healthy Aging Series 7 by Chennai Menopause Society on international webinar on pelvic organ prolapse in midlife. We have eminent professors and excellent gynecologists here to share their knowledge and wisdom. Let's start the webinar with the traditional Kuttuvilaku lighting. Chitrakala, next slide. Thank you. Next comes the prayer song to invoke the deities by Dr. Shobana Mahadevan, who is a nightingale of the Chennai Menopause Society. Dr. Shobana.
Gananadane, Gunabodhane, Gananadane, Gunabodhane, Gajamamuka, Gatini, Ayya, Gananadane, Inaye illa, Peruvarvine, Inaye பெருவாழ்வினை இனிதியுமோ தனிநாயகா இனிதியுமோ தனிநாயகா கணநாதனே சதுர்வேதங்கள் ஓம் ஓமென தூதி பாடிடும் பரம் ஜோதியே பரமாமலர் தொழுதேனையா பரமாமலர் தொழுதேனையா பரிந்தே அருள் செய்வாய் மெய்யா பரிந்தே அருள் செய்வாய் மெய்யா கணநாதனே குணபோதனே கஜமாமோகா கதினி ஐயா கணநாதனே.
Midlife prayer by Dr. Geeta, Executive Member of Chennai Menopause Society.
We pray to God to give us grace to accept the midlife physical changes and gently renew our strength. Guide our hearts, our mind, and body to navigate the way, and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond memories of their lives, and also for those sitting in the doctor's office or who are in bed asking for healing touch. On this day, may all the midlife and menopausal women have the gift of joy, hope, and good health. Thank you, God, for the promise of hope you hold out to all midlife and menopause women and inspire us to give this gift of hope to others.
Thank you, Geeta. Our President, Dr. Hepzibah Kribamani, will give the welcome address now. Madam is the current President of Chennai Menopause Society and past President of OGSI. Madam.
Unmute.
Madam, you're muted still.
Madam.
Very good evening and warm welcome to one and all. Respected Dr. Ambuja Madam, Dr. Sudha Sharma, Dr. Kurian Joseph, Dr. Reed Allinson, Dr. Jagdish Gandhi, Dr. Hafiz Rahman, Dr. Mala Raj, Dr. Tamuchelvi, dear friends and delegates. It's a moment of pleasure to welcome one and all on behalf of Chennai Menopause Society. I'm extremely honored to welcome Chief Guest, Dr. Ambuja, President of Indian Menopause Society, who is a dedicated menopause physician and keen on starting menopause clinic throughout India. It's my privilege to welcome Dr. Sudha Sharma, my friend, Secretary General of Indian Menopause Society, who always supportive and encourages in all our activities. It's my proud privilege to welcome my friend, my classmate, Stanleyan, and a worthy son of my favorite professor, Dr. A.K. Joseph. He is a pioneer in gynec endoscopy. He has trained many doctors in India and abroad. He is also one of the best obstetricians, especially a very good in conducting instrumental therapy. Welcome you, Priyan. It's my honor to welcome Dr. Reed Allison. Though he's from California, he immediately said he would join. I think today he has to conduct some workshop. He may not be able to join. He is a director of a Southeast Urogynecology and Aesthetic Vulvovaginal Surgeon. I welcome. I'm delighted to welcome Dr. Jagdish Gandhi, who is a lead consultant urogynecologist, eminent speaker, and a teacher. My warm welcome to you, sir. I welcome Dr. Hafiz Rahman, who has conducted largest series of laparoscopic hysterectomy in the world. And he has removed the largest uterus, I believe, 4.9 kg. And my special welcome to young endoscopist, aesthetic gynecologist, Dr. Mala Raj, who is doing a lot of work and training and endoscopic training. I welcome you, Mala. And I welcome Dr. Tamuchelvi, who's a young gynecologist, urogynecologist, and our secretary, Chennai Menopause Society. And it is my pleasant duty to welcome our eminent chairpersons and all the participants. Today, theme is pelvic organ prolapse in midlife. As we all know, the pelvic organ prolapse increases with age and parity. And in midlife, it affects reproductive and sexual activity in midlife. With a better understanding of the etiology, we can, to some extent, prevent pelvic organ prolapse also. Actually, the incidence of pelvic organ prolapse is underestimated. It has its own economic burden on a healthcare system is substantial. Because of this social burden, a lot of surgeons continue to be working on that, and they have a hope to do a lot of things successfully to reduce the risk, minimize the risk, and variety of surgical approaches have been done throughout the world so that to optimize the treatment, to enhance the durability, to minimize the risk and shorter recovery. Today, I'm sure we have a galaxy of experts to discuss various aspects of management of pelvic organ prolapse in midlife. I'm sure we will be benefited from today's webinar and we learn to manage pelvic organ prolapse. Once again, I welcome one and all.
Thank you, madam. We have two guests of honor this evening. Dr. Sudha Sharma, Secretary General of Indian Menopause Society and former Professor, Department of OBG, Jammu. Madam, a few words.
Thank you, Dr. Padma. A very good evening, dear friends. Today's chief guest, dynamic president, Dr. Ambuja, Dr. Kurian, all the organizers, Dr. Tamil, Padma, Dr. Mala, everyone present over here. We have eminent speakers and chairpersons. So at the beginning, I want to congratulate Dr. Hepsiva and the entire team, for organizing this event and always choosing so very important and challenging subjects for discussion. Hepsiva, you are unique and innovative. We all agree. We all know that, pelvic organ prolapse is seldom life-threatening, but is always life-altering. Pelvic floor goes through a lot during pregnancy and it takes some time to recover, be it after C-section or vaginal. I just want to share, few myths which we had once we were UGs and once we were graduates, and now, very much clear on these doubts. Like we always used to say that it is the difficult labor or the instrumental delivery that causes prolapse, but it can start long before delivery in pregnancy itself, as carrying pregnancy does put a lot of strain on support system, we all know. We always used to think that C-section would prevent prolapse, but on the other hand, not always. It's our own genes that would determine the muscle and tissue strength. Women born with weaker tissues at a higher risk of having prolapse. Then we also used to think that with each birth, it will worsen. But few studies have shown that women who have never had babies before prolapse alongside women who has multiple babies, they also, have prolapse. So I'm very sure that we are going to clear with all the myths we have had earlier, and the wonderful speakers and the faculty chairpersons we have on this platform. We are going to learn more and more. So all the very best for today's webinar, and waiting to hear more from all of you. Thank you so much. And thank you for inviting me and making a part of, Chennai Menopause Society. I love to be amongst you. I love you all. Thank you.
Thank you, madam. Other chief guest of honor, Dr. Kurian Joseph, director of Joseph Hospitals. Sir needs no introduction. Over to you, sir.
Good evening. Can you hear me?
Yes,
Yes,
Kurian.
Good evening. Congrats to Chennai Menopause Society. Congrats to my dear friend Hepsiba for organizing such an important meeting on such an important subject. I'm so happy to see such familiar faces. I'm coming out of hibernation after 3 months, and I took I was literally ordered to take the invitation by Hepsiba. I accepted it. Thank you very much. I was reviewing the whole thing and seeing how things change in life. In the pandemic, so many things have changed. We've all changed so much. Some of you have grown younger, some of us have grown older. But whatever it is, the bottom line is change is there. So we must make or sort of take advantage of these things that are happening. I like the words which the late comedian Bob Hope mentioned many years ago. He said, "Do you know how I learned to dance?" So everybody wondered, how this guy could dance. You're such a nimble dancer. He said, "I had 6 brothers. And with the 6 brothers, when you try and wait for your turn to the bathroom, you have to keep practicing your steps. So that way, one has to keep changing and evolving. So when you get a patient who's coming with a pelvic organ prolapse and problems around at menopausal time, I think the first simple thing is listen to the patient. Don't immediately label it as wall prolapse or UV prolapse and push it. Because when you listen to the patient, you will very often come up with points which will be very important in her treatment. We recently had a patient who had a laparoscopic hysterectomy in 2009. And she came fluent from Calcutta saying, "Doctor, something is coming out vaginally." So the doctor there said, "Go back to the doctor who had done the hysterectomy, check and come back." When she came back, all she had was a tag of vaginal tissue. We just cut the tag of vaginal tissue, stitched it and sent her back. She flew in all the way from Calcutta for that. So listen to the patient. After you listen, examine the patient. Remember, if you're the treating doctor, you must know the picture. What one calls a stenosis, maybe nothing there. What one calls as prolapse may not be there at all. A cystocele may be mistaken for something else. So after you listen, examine the patient, then assess what you think would be the best for them. And finally, then only decide, discuss with the patient and do what's needed. So simple thing is you lead the patient. Listen, examine, assess, and then diagnose and treat the patient. If you can do this, I think your patient would be much better off. All of you can learn the tricks of the medical treatment, surgical treatment, etc. But where different people differ is in correctly using a technique for a given situation. So I thank the society, thank Chennai Menopause Society, and nice to see all of you there. I thank Dr. Ambuja and Dr. Sudha for the kind invitation. Thank you very much.
Thank you.
Thank you so much, sir. Our chief guest for this evening, Dr. Ambuja Sharanur, will address us now. Madam is the President, Indian Menopause Society and retired professor and HOD, OBG Department, Osmania Medical College, Hyderabad. Over to you, ma'am.
Unmute, Dr. Ambuja.
Good evening, everybody. Very happy to come back to Chennai again. I love always coming to Chennai and be with you all. Dear Korean, dear Hepzibah, dear Mala, everybody. So yeah, all familiar faces, very nice to see you all. And I congratulate Hepzibah and all the Chennai Menopause Society for arranging such a wonderful program, which is very, very important. You know, the name itself, changes, not challenges. The Healthy Aging series is a unique program of its kind, what you have arranged, and you are doing again and again new innovative things is really great. As all of us know, pelvic organ prolapse is not new to us. From the 50 years onwards, from the time we joined medical college, before that itself, our grandmother suffering and all, we know that this is existing. There is treatment that is there. Until now, the same thing is continuing. Means, where are we going wrong? There are so many classifications coming, like quantification, pelvic organ prolapse and all. Nothing is satisfying the patient. Really, to say the truth, how many of us following in our outpatients the quantification methods? When I go as an examiner also, I ask all my colleagues or the students, just for the examination's sake, they will learn by heart the quantification and they'll come and vomit it out in front of the examiners. So do we need something more to be done? Because we have so many experts, so many surgeons, and pelvic organ prolapse itself is paid into a separate entity. Previously, only the general gynecologists used to treat. And I feel that time the wall prolapse is less, but now doing all sorts of surgery by so many people, abdominal hysterectomy for the pelvic, laparoscopy has become such a fashionable thing. Even for the POP, laparoscopy is being done, and they're all coming with the wall prolapse. So again, relook into the POP is essential. And second thing is, we human beings are only suffering with the POP. We can't think of it in any other living organisms because they're all four-legged and we are only two-legged, having the weight bearing and all these things added to that. In the present century, the obesity has become a major problem adding to that one. All these things, I think today the problems will come out, and we are eagerly looking for that, Hepzibah. And you have selected such a good, eminent speakers. Thanks to you. Otherwise, the corona, we would not have had the chance to listen to all these people. Thank you all for giving the opportunity to join you, and you made me a part of your society. Thank you very much.
Thank you so much, ma'am. We also request you to release the newsletter.
Thank you very much. I'm eagerly waiting for that one. So nice it is. Hepzibah, it is so nice. And Chennai Menopause Society releasing newsletter every time is simply exemplary. And we congratulate you for this one. Thank you very much.
Thank you, ma'am. Thank you for releasing it.
Congratulations, Dr. Hepzibah, for such a wonderful year.
Thank you. Thank you, ma'am.
Thank you so much, ma'am. Now we start our sessions. Session 1 is chaired by Dr. Shanti Gunasingh and Dr. Dhanalakshmi. Dr. Shanti Gunasingh, past president of OGSI and former director, Institute of OBG. Dr. Dhanalakshmi is a professor, Department of OB-GYN, SRI, Sri Ramachandra Institute of Higher Education, and Honorary Secretary, OGSI at present. Madam, over to you.
Thank you, Atma. I thank Chennai Menopause Society for having given us an opportunity to chair this session on this very important topic, pelvic organ prolapse. We know that pelvic organ prolapse occurs due to injury to the levator ani muscles and failure of the connective tissue connections between the pelvic organs and the pelvic side wall. And it is very, very important to know the exact anatomy so that we are precise in giving an appropriate treatment. So we have an excellent speaker, Dr. A. Tamil Selvi, to give us a clear idea about the pelvic floor and the uterine supports. So can I have the, yeah. So Dr. A. Tamil Selvi is an UG and PG alumnus of Madras Medical College, and she had a specialist registrar training CCAST at London Deanery and clinical fellowship in urogynecology UK. She is now the senior consultant urogynecologist and pelvic floor surgeon at Madras Medical Mission Hospital and Mangai Women's Healthcare. He is the editor of Principles and Practice of Urogynecology and co-editor of Ambulatory Urology and Urogynecology textbooks. And she is a prolific publisher of articles and a member of various prestigious organizations, and with a special interest being creation and implementation of skill training in ONG, academic training of junior doctors. She's a course convener of MRCOG Part 2 and Part 3 courses and a Part 3 MRCOG examiner. She's a fellow representative, International Representative Committee, RCOG South Zone, and of course, our dynamic secretary, Chennai Menopause Society. Dr. Tamil Selvi, please.
Thank you so much, madam, for your kind words, and you really took your time to read through all of that. Thank you so much, madam. So at the outset, I think my job has been done easy by both our guests of honor and our guest, Dr. Ambuja madam, actually talking a bit about the prolapse etiology by themselves. So the prolapse etiology, they themselves have set the scenario, saying why it is important. And Shanti madam has correctly said, anatomy of the pelvic floor and uterine supports is essential to actually understand which surgery works for these patients. So a success of a surgery is dependent on several factors. And one of the most important is the knowledge of the anatomy, and which we can't agree, because that's how we start our medical school. We start with the A anatomy when we enter into medical school, because we need to know that before we proceed any further. Now, when it comes to pelvic floor and the uterine supports, as we can see, the uterine support is dependent on several factors. You have the uterus, which is Repugnant is related to the bladder in the front and the rectum at the back. So the interrelationship between the organs is important, and it rests on the musculature, the pelvic floor musculature. The integrity of that is important. But is that all is important? What is more important is also the bony anatomy, which we do tend to ignore. The bony anatomy is very important because if there is a divarication at this juncture, the ipsus pubis, things will start to fall apart. And when they fall apart, there is a higher tendency for prolapse. So patients who had fractures of the pelvis also have a higher incidence of prolapse. And this takes us back to what Dr. Guri and Joseph was saying, listen to the patient. So when you take a history, you listen to the patient, you actually will find out why a nulliparous woman has got a prolapse. Maybe she's had some fracture to the lower part of a pelvis or in the anterior part of the pubis, because we do see patients occasionally with these problems as well. So the bony pelvis is actually kept in place by all these ligamentous structures. And these ligamentous structures, I'm not going to go through them because this is not an anatomical class, but what we need to know is we have important bony landmarks in the pelvis, which will help us in planning the prolapse surgeries and also help us in assessing the prolapse. And one of the most important thing is the ischial spine. The ischial spine with the sacrospinous ligament and the ischial spine along with the sacrotuberous ligament form very important landmark, and along with the obturator membrane in the recent past, they are important landmarks for us to know in assessing the prolapse patient as well as in planning the management. So the prolapse happens when this pelvic floor fails, and that is our understanding. But does the pelvic floor fail on its own? Because when the pelvic floor fails, it is not only the uterus, it can be the bladder, which can descend down, which can be the rectum, which can descend down. So we can get an anterior compartment prolapse, a middle compartment prolapse, or a posterior compartment prolapse. So what are the other supports? Apart from the body support, what are the two important supports which actually determine or which prevent or which can predispose to prolapse? That is the muscular support and the fascial support. The muscular support is just not the pelvic floor. That is something we need to understand. The muscular support, though predominantly it is the pelvic floor, the levator ana complex. The pelvic floor is not synonymous with levator ana complex. The pelvic floor consists of all the other muscles as well. So disruption of these muscles will also interfere with the normal positioning of the pelvis, normal positioning of the pelvic organs, and the levator ana complex can fail secondary to the other superficial muscular structures which fail, and that can also lead to prolapse. So though levator ana complex is the predominant thing, we need to know what exactly we are dealing with when we approach the prolapse from the perineum for us to understand how exactly we reconstruct the surgery when we do these repairs. So if we look at the muscular supports, apart from the skin and the subcutaneous tissue, we all know the superficial perineal muscles, because that is what we deal with when we have a delivery or vaginal delivery. So stretching of these we do know. So inside the just interior to the superficial perineal muscles, so we are going from the perineum towards the levator ana complex. So when we do this after the superficial perineal muscles, then you enter into the deep transverse perineum, where in the deep transverse perineal membrane encloses the deep transverse perineal muscle. The deep transverse perineal muscle is an important structure which is triangular in area, which actually helps in the fusion around the urethra, fusion around the vagina, and also helps in keeping it tight. So it is an important structure as well as important as the levator ana complex. Now, when we go deeper to the deep transverse perineal muscle, we find the levator ana complex with this pubococcygis, iliococcygis, and ischiococcygis component. And this is from viewing the levator ana complex from down below. When we look at it inside, you can see the levator ana complex actually is attached to the pelvic side wall. So the pelvic side wall attachment of the levator ana complex is the arcuate line, or called the arcus tendinous of the levator ani. So there are two arcus tendinous on the pelvic side wall, arcus tendinous levator ani, and underneath this is the arcus tendinous fascia, to which the fascia are attached. So if you look at the perineal muscles, the levator ana complex, you can see that the attachment to the bony pelvis is as important to the attachment to the overlying structures. So That again comes to the interrelationship between the bony support as well as the muscular support, which seems to be interrelated. So it's just the bone and the muscles which are interrelated. Overlying the muscular structure is the fascia. We have the facial structure which can provide the support to the pelvic organs. And these fascia splits into anterior and posterior. Let's look at them. Now, this is a very important component which everyone dealing with prolapse need to understand, especially the postgraduates need to understand this concept. Now, the fascia is a continuous structure. It continues from the one side of the pelvic side wall to the other side of the pelvic side wall. It continues from the vaginal outlet or from the urethra. It continues from the perineum and goes upwards and goes proximally towards the sacrum. So it is a continuous layer if you look at it. And this layer actually condenses at certain areas to form what we have been calling as ligaments. The ligaments are just condensations of this endopelvic fascia. So at the proximal end, we have the uterosacral cardinal ligament complex. The uterosacral complex actually is a suspensory level of support. When we say suspensory level of support, what it means is it attaches to the lower 1/3 of the uterus and the upper 1/3 of the vagina proximally, and it is attached more distally towards the sacrum. So basically, it suspends the uterus from towards the sacrum. So any anatomical correction should aim to suspend the uterus in this manner so that it can sit on the levator plate, which is the levator ana complex. So this is called the level 1 support, the suspensory axis. And the cardinal ligament along with the endopelvic fascia on either side forms the lateral attachment. So the lateral attachment is to the arcus tendinous fascia pelvis. The arcus tendinous fascia pelvis on either side of the bony pelvis actually attaches the fascia. So anteriorly, it splits into two. It goes anteriorly and posteriorly. Anteriorly, it is called the pubocervical fascia. This portion is the pubocervical fascia, or the vesicovaginal fascia, which lies between the bladder and the uterus. And posterior to that is the rectovaginal fascia. So the anterior and the posterior portions of the fascia together with their attachment form the attachment axis. Now, when this attachment axis is disrupted, either when this becomes distended or becomes thinned out, the middle compartment starts to prolapse, which can be the cystocele, and which is what we refer to as the central cystocele. Now, when this attachment to the arcus tendinous fascia pelvis gets disrupted, then it starts to sag to one side and you develop a lateral prolapse, which is called the lateral cystocele. So there can be actually a detachment of the attachment, or there can be a distension of the attachment. Depending on that, your type of prolapse will vary. Now, traditionally, we are still doing an anterior repair for the middle compartment prolapse, where we just bring the fascia together. And so, not surprisingly, we have a very high recurrence rate. So the recurrence rate is quite high, around 11 to 15%. Why? Because we are treating both the detachment as well as the distension of the fascia in the same manner. And we are yet to identify an easy way of attaching it. We do have techniques where we can attach the fascia, the pubocervical fascia, onto the arcus tendinous, but doing it vaginally is a bit tricky. So because it's not easy to access the arcus tendinous fascia pelvis vaginally, so laparoscopic entry also has got its own problems, because you're going closer to the obturator membrane and there is a high tendency to injure the obturator vessels. So we are looking at more at innovations which can actually help us to anchor this tissue with minimal damage. So that is the next step in the prolapse surgery. So when we finish the attachment axis or the level 2 support, then we move over to the lower 1/3. In the lower 1/3, these fascia are fused to the urethra over here and fused to the perineum over here. So when the urethra support, when the fusion support is lost, there is hypermobility of the urethra, which can cause urinary stress, urinary incontinence. When this actually fusion towards the perineum and the perianal area gets disrupted or becomes relaxed, there is widening of the genital hiatus. And as Dr. Ambuja was saying, because we have adopted the standing posture, because we become biped rather a quadruped, all this widening of the genital hiatus will actually predispose us to actually push things downwards, especially in obese patients. And that is one of the reasons a widened genital hiatus is a very high risk factor for patients with prolapse recurrence. So when we correct prolapse surgeries, we need to look at all these components to see whether all these are addressed to achieve a success on the prolapse surgery. So as Dr. Kurian said, just looking at a patient and saying, well, it's a wall prolapse, let us do a laparoscopy called popexy, or just looking at it and say whether the uterus is coming down, let's do a vaginal hysterectomy, is not going to be of any benefit until we understand the anatomy and thereby evaluate the function for the patient and then treat all the components of the pelvic floor as we would do. So we have to, it is an integrated approach looking at the muscular support. You can see this is the muscular support on which this is the levator plate on which all the pelvic organs rest, and the pelvic organ resting is actually promoted by the fascial support where the uterosacral ligaments actually push it backwards and make sure it lies on the levator plate, and all the other structural elements help in this manner. So we can compare why these are interrelated by looking at this analogy. So if you consider the pelvic floor to the water, and this is a ship which is docked in the harbor. So if you think this pelvic floor is basically the water, and this ship is your pelvic organ, and these are the ligaments. As long as there is enough water, these ligaments can sustain the strain of the ship. Whereas when the water actually gets disrupted or becomes, the water level comes down, what happens? Only the ligament has to support it. So when does the water level come down? The pelvic floor can relax, as Dr. Sudha was saying. It can lose its tone, or it can become relaxed in pregnancy, in constipation, in patients with chronic constipation, chronic obstructive airway diseases, childbirth. So there are several factors. Most of it can come down. So when that gets disrupted, the fascial support fails and the fascia gets disrupted and prolapse can happen. We need to actually look at this, and the prolapse can be in compartment depending on which type of fascial support is actually being, which actually has got disrupted depending on the pelvic floor anatomy and the pelvic floor tone. So we need to look at this anatomy as a wholesome picture to identify how to treat this patient. So over to all the other faculties who will be telling us how to address these issues when there is a failure of the anatomical support. And thank you, Hepsi Madam, for the opportunity.
Thank you, Dr. Tamil Selvi, for your excellent, precise, and lucid presentation. You have stressed on the bony scaffolding, which is also equally important, like muscular and our endopelvic fascia and all these ligaments. So thank you very much. You have really given us the basis so that we can see how best a patient can be treated. And it's really unfortunate that my co-chairperson is not able to join because of poor net connectivity. So now can I have the CV of the next speaker, please? So we understand that any treatment initially would be medical, and only if it fails or if it is mandatory, we would go on to surgical management. So to give us an idea about non-surgical management of pelvic organ prolapse, we have an esteemed speaker, Dr. Jagdish Gandhi, lead consultant urogynecologist, Hull University Teaching Hospitals, UK. He is Tier 3 educator in postgraduate OG medical education and training. He is an FRCOG examiner for RCOG and extensive experience and training in urogynecology and in the use of tapes and mesh for incontinence and prolapse and Botox for the overactive bladder. He's an editorial member of Indian Obstetrics and Gynecology Journal, and he has published widely, especially in urogynecology. And he has been a contributing author for chapters in several urogynecology publications. Dr. Jagdish Gandhi, please.
Um, Good afternoon in India and good morning in UK. I'm just halfway through my clinic, and it's so nice to see Salvi and Hapsi, madam, and I'm delighted to share some of my thoughts with you. I'll just try and share the screen and see if you can see my slides. Can you see my screen?
No, sir.
Not yet, sir.
Not.
Not yet. Okay.
Not yet.
Can you see my screen now?
Yes.
Wonderful. Okay, I will just bring presentation.
Tricolor?
Yes, ma'am.
Yeah, can you? Yeah. Seen.
Okay. You can see my screen, yeah?
Yeah,
Yes,
yes.
sir. Yes, sir.
Okay, and probably you can see me as well. Never thought in my life that we will be talking in distance similarly, but I'm delighted. Let me just switch off one of these slides. Right. Okay, I'm going to talk about non-surgical management of prolapse. Very kind introduction. Thank you very much. And I'm delighted that we'll be talking a few things. This is our hospital, Hull Hospital Teaching Institute, and Women's Hospital is separate building part of it. I'm sorry, I just need to move some of the part of screen away so I can talk. Yeah. Okay. Causes of prolapse, it has been discussed in detail. I don't have to go through a lot of it. And the management option. The first one, we always talk about do nothing. If they can continue with conservative management, and we'll talk about a bit more, lifestyle changes, and pelvic floor exercise. So these are the mainstay of non-surgical management. So what causes pelvic organ prolapse? We heard about it. It's mainly the weakness, which could be due to underuse, or it could be due to childbirth. Having said that, 20% nulliparous women also have prolapse, which is probably not surprising. So there are other factors as well. Menopause is one of the major factors, along with overweight. When there's a BMI of more than 30, there's a good chance that you will get a prolapse. Constipation, persistent cough, and heavy lifting puts the pressure on the pelvic floor. Now, very often, patients do ask that how much should they be lifting, or how can they avoid pressure on the pelvic floor? I'm sure you have a standard answer in your practice as well, but in general, if you have got approximately 10 to 15 kilogram of weight divided in 2 arms, is probably the right amount. As regards to the pressure on the pelvic floor, my simple advice is any job, when you do, if you have to hold your breath, don't do it. Holding the breath puts increased amount of pressure intra-abdominal and onto the pelvic floor. So that is very simple and quite understood concept. previous hysterectomy and genetic factors are also contributory as well. The non-surgical management, as I mentioned, first principle is do nothing. If there are no symptoms and you found incidentally any prolapse, the chance that it will go worse is only 20%. So in 80% of the patient, you may be giving treatment, but it may be completely unnecessary if you treat every single clinical finding. The lifestyle changes are most important. Losing weight, as we mentioned, pressure intra-abdominal as well as from excessive weight does weaken the pelvic floor. Managing cough. It's not such a big issue probably in India, but across in the cold countries, the winter months and all round, the chest conditions are quite common. Stopping smoking and avoid heavy lifting, which I mentioned. The high impact exercise, for example, trampolina and aerobic exercise, one need to avoid. So what does pelvic floor exercise actually means and how does it help? Increasing in muscle volume is one of the job it does. And that's how it helps stopping the sinking vessel, or what Salvi just mentioned about the good support from the pelvic floor. It also closes the levator hiatus and shortens the muscle length. And that does help the ligaments around to get back to some form of normality. It elevates resting position of bladder and rectum. And if you have got a neck, which is having a pelvic floor contractions when you have got sudden possibility of incontinence. Now, at that time, if you have a cough and think that there may be a leakage, the neck effect of sudden pelvic floor muscle contractions can be made trained, and people can then have a good effect on the incontinence. So how do we do pelvic floor exercise? As perhaps you know, there are two different kinds of exercise. One is the short hold, another is the long one. And the main role of exercise is it either avoids surgery or it delays. The regimes are two, as I mentioned. One is slow pull-ups, in which you tighten the muscles, hold it up to the count of 10 if you can, and then release. Now, this will build endurance, and that will help. If there are fast pull-ups, that means you suddenly contract and release, that help to react when you have got cough. And I mentioned about neck, and that is where it helps. That when you're going to cough, you suddenly contract the muscles, pull it up, and that helps. And how often you need to do? You need to have 10 of each contractions, slow pulls. So count up to 10, pull it up, hold, and then release. Or initially, you may not be able to do more than 2 or 3 or 4 seconds, but then slowly it will get better and better. And 10 quick pull-ups. Improvement usually you notice at 3 to 6 months, and there are some gadgets which can help with pelvic floor exercise as well. So this is one of the biggest trials we have in the UK. It was a POPI trial, pelvic organ prolapse physiotherapy. It was one of the largest RCT, and there were 2 groups. One was the intervention group, where 16 weeks pelvic floor exercise with 5 physiotherapist appointment, and the exercise were taught along with lifestyle advice, and home exercise program was given. In the control group, as opposed to that, there was no contact with the physiotherapist, and literature was given in form of leaflet about lifestyle and pelvic floor exercise. Women with stage 1 to 2 or even up to 3, they were recruited. Now, the conclusion was that in the intervention group, there was significant improvement in prolapse symptoms at even 12 months. So somebody who had a good pelvic floor exercise with physiotherapist, understood exactly what to do and so on, was benefited. Now, there are sufficient evidences to support pelvic floor muscle training in the management of pelvic organ prolapse. Well, if it doesn't work, what do you do? Well, you get your pelvic floor laminated. We were used to use the mesh, but no more here in this country. If the pelvic floor muscle training fails, you need to find out why it has failed. Very often, it is simply patient is not aware about which pelvic floor muscles they need to contract. And often they will contract either tummy muscles or even buttock muscles. So biofeedback and electric stimulation can help people to identify these muscles and get better training. Now, there are various types of biofeedback: electric stimulation, or there is a periometer, or indeed vaginal cones. Let's talk a little bit more about biofeedback. It is the awareness of physiological function. So people will know whereabout are these muscles and what they can do. Women will be able to identify and contract these muscles using signals because electric stimulation is coming up there. Why should we try biofeedback? The biofeedback, it can improve efficacy of pelvic floor muscles, and biofeedback muscle training performed together, pelvic floor exercise, has got greater advantage than pelvic floor muscle performed alone. And this is, as I mentioned, often due to the awareness of the pelvic floor muscles. Now, this is one of the electric muscle stimulator in which the little applicator goes inside the vagina, which has got the metal plates, and the electrical stimulation sent from this handheld machine. This is quite advantageous in people who are unable to activate pelvic floor muscles contractions, or they are unable to have correct muscles. Stimulating these pelvic floor muscles through electric stimulation regularly can help. Usually the benefit is noted at about 3 months. Now, this is about the periometer. Periometer is a simple device which is kept in the vagina, and the contractions are then looked at the computer screen. And when there are contractions, then patients can appreciate that, yes, the muscles are contracting and is helping. And it can enhance the effectiveness of Kegel's exercise. Now, personal pelvic floor exercise or vaginal cones. Again, as I mentioned, this is the pneumatic personal pelvic floor muscle contractions, or the vaginal cones, which are kept for about 15 minutes twice a day. And this is what the cones look like. They come in a little capsule, and you have got various amount of weight, which you increase it slowly and keep it in the vagina for 15 minutes or so. Now, the very first time reduction of prolapse was done was by Hippocrates, and he used half of pomegranate. Now, we have moved since then many centuries, and we have got all sort of different kind of pastries available. They are non-toxic, medical grade silicone, and they are biologically inert, and it does not absorb any vaginal odor. They are quite pliable, quite soft, and it can be autoclaved or soaked in Sidex. They are reusable, available in very many sizes and shapes. And the outer diameter is the one which is important in fixing up. So from here to here is the size, and they come in various sizes. So why should we consider pastry? This is one of the recognized alternative to high-tech surgeries. As you know, surgery has got its own disadvantages. It's quite invasive. However, simple pastry in early cases of prolapse can be very effective with low risk of complications. And it could be beneficial not only for prolapse, but also for urinary incontinence with satisfaction rate about 70 to 90% symptomatic relief. It can also prevent problems if left untreated. So if somebody has got prolapse and you don't treat it at all, it may worsen, but pessaries can help. The main purpose of pessary is to relieve the discomfort of pelvic organ prolapse. As you know, that nagging, dragging sensation, or in fact a bulge coming down, that can be supported by pessary. It may improve prolapse or prevent one from worsening, and it may uncover the presence of any hidden incontinence. As you know, with marked cystocele, usually there is a slight kink in urethra, and you have got incontinence, but it is occult. So when you correct by operation, suddenly patient will say that, well, my prolapse has gone, but you have given me now incontinence. Similarly, if there's no incontinence, and if you use the pessary or operation, then at least you've got a test to say, well, with pessary, there's no incontinence, so operative management is likely to met without any long-term incontinence problem. And this is the diagnostic help from surgical point of view. Now, ring pessaries are the commonest one used. They are pretty cheap in a sense. In UK terms, it's about 3 to 4 pounds, which is 300-400 rupees for a simple ring pessary, and more complex pessary can go up to 40 or 50 pounds, 4,000 to 5,000 rupees. So these are the two kinds of pessary. This is ring without support, and this is with support, which could be quite helpful in people who have got cystocele. They are commonly used, simple to fit, they are round, flexible, they help urethra and bladder neck, and the membranes provide additional support for cystocele. It's useful for a first or mild second degree uterine prolapse associated with mild cystocele. And they are very easy to fit. They do go and stay in the posterior fornix and at the front, just under symphysis pubis or at the level of symphysis pubis. Galvan pessaries are another one. They are quite awkward, and that is why probably they work. Once they are in the vagina, they are very well supporting the organ. They are most commonly used for uterine prolapse. It provides support for third degree or even procedentia patients, and it's less support mainly for rectocele. And once they go in, this is how they fit in. The plate remains at the top and the knob remains down. Very often there is a vacuum gets created at this level. There are few holes where discharge can come down, but the vacuum could be quite problematic, because when you want to remove the pessary, a smooth knob not necessarily always comes down. And then you need to put a little finger above the plate, break this vacuum, and then do the replacement. These are the do not break one. They are similar to air-filled pessaries, and they are soft silicone. They occlude upper vagina and support the uterine prolapse. They are useful for cystorectocele, and they're a good support for prolapse after hysterectomy. The cube pessaries, they have got 6 different angles, and very often they are quite useful for cystorectocele as well as third degree of prolapse, especially when there is poor muscle support. Vaginal wall, they are kept apart by the 6 different angles, as well as there are some holes which can drain the discharge, and there's a little string with which patient even can pull it out. Now, there are a few cases where you should avoid the pessaries. One is very severe untreated vaginal atrophy, because that will again scratch the walls. If there was unknown vaginal bleed, the pelvic floor inflammatory disease, or abdominal pap smear, patient who has dementia and may not come for follow-up, and expected non-compliance. So those are the ones which you need to be careful. Sexual activity is possible with simple pessaries, such as the ring pessary. And the today's seminar is the pelvic organ prolapse in mid-age, and probably this will be the question which may be asked. Even patient can manage pessary themselves, simple pessaries or soft pessaries, they can take it out and put it back. Obviously, the occlusive pessary like Gallhorn or Donuts, it's not always possible to for patient to take it out or have intercourse. There are some patients in which you can almost say that pessary will probably not work. One of them is the short vaginal length from previous operation, or there's a wide introitus, there's a posterior wall defect, there are patients who don't want surgery, and patient who had a previous hysterectomy or prolapse surgery. The pessary fitting, the rectum and bladder need to be empty as much as possible, and you need to impress that pessary treatment is like trial and error. We give the example of going to a shoe shop. You don't find a shoe which fits perfectly first one you try. So sometimes you have to try a few before you get correct pessary. There are many different sizes and shapes, and don't memorize which pessary is best for which one. Just start with very simple ring pessary. It should be large enough for its designated function, but small enough to prevent any discomfort. Measuring the width, insert your first two fingers of dominant hand and keep them deep in posterior fornix. Approximate size by using the fingers to determine the width, and also spread the fingers wide to measure how much will be across. Sometime following previous hysterectomy, especially vaginal one, the shape of the vagina could be like a cone shape, very much narrow at the top, and you will then find difficult to get the correct pessary fitting. Remove the fingers and compare the pessary size. The outer diameter is the one to consider, or outer gauge. The slip this in the vagina, curving posteriorly, release and allow to spring open in normal shape, and push it deep into the vaginal wall. Tuck it securely behind. Sorry, I can hear. Is there an instruction for me? I can hear somebody in the background.
No,
Okay.
sir. Sorry for the interruption.
Okay. And then tuck securely behind pubic bone anteriorly and under the cervix, a present. After the fitting, ask the woman to bear down and look at any descent, and then ask them to walk around for a few minutes, go and pass water and see how things are. You can use vaginal estrogen ring every 3 months in older women, or local cream to use twice a week, or even the pessaries, the estrogen pessaries. Follow it up 4 to 6 month interval. Observe for a vaginal tissue reaction like discharge or irritation, ulcer, and determine if there has been any improvement. Complications, you can have increased discharge or smell, ulceration, or pelvic discomfort. Sometimes it gets impacted as well and may require anesthesia. There could be scar or granulation tissue around the pessary. So, take-home message. There are non-surgical management options for prolapse. For example, do nothing, as we mentioned, lifestyle changes, pelvic floor exercise, and if necessary, help with biofeedback, electric stimulation, vaginal cones, and the pessary treatment. So even there is a hopeless case, you can always have something to try. And usually people who try pessary, especially elderly who do not want operation, or they are too ill to have operation, pessary could help for many years. I have got some patients who are using pessary for up to 20 years or so even. Thank you very much indeed.
Thank you, sir, for your excellent talk on non-surgical management of pelvic organ prolapse. You have nicely stressed that doing nothing, even helps, because only it gets worse only in 20%. So we have to think about that point in certain really elderly patients. And you have nicely stressed on lifestyle modification, and of course the pelvic floor muscle training, which is better if it is aided by a physiotherapist and probably by biofeedback and electrical stimulation. And you have also stressed nicely on the pessary management, which is the first procedure which is done by a postgraduate in a gynec OPD. So it is really, you have nicely given us the indications, all problems. Thanks a lot for the very clear talk. So, and
Thank you very much.
yeah.
I have got clinic to go back to. So would you forgive? Would you need
Yes.
me for any question? I hope it is.
Now,
It
we
was
do
simple.
not have any questions in the chat box right now. So I think probably
Thank you. Thank you so much, sir.
Thank you very much.
Thank you. Thank you. Bye for now.
Yeah. I should also thank Professor Hepzibah on behalf of myself and my co-chairperson for having given us an opportunity to chair this session. Thank you.
Thank you.
Thank you, ma'am. Thank you, Shanti, ma'am. Session 2. Session 2 is about laparoscopic PECs and will be chaired by Dr. Premlata, consultant and HOD, Dr. Mehta's Hospital, and Dr. Meera Raghavan, senior consultant, urogynecologist, and robotic surgeon at Apollo Hospitals. Madam, over to you.
Good afternoon to all. At the outset, I thank Dr. Hepzibah for giving me the opportunity to chair this session, and I'm greatly honored to introduce Dr. Hafiz Rahman, who is a renowned laparoscopic surgeon, and he has done more than 1,20,000 laparoscopic surgeries, and he had done first gynec cancer surgeries in United Arab UAE, Bangladesh, Sri Lanka. He has trained so many gynecologists in laparoscopy all over the world. I mean, not only across the country, from Bangladesh and Sri Lanka. He is a recipient of numerous awards and authored many books. Sir, we are very eager to hear your talk on laparoscopic sacrohysterectomy. Over to you, sir.
Yeah. Let me just share the screen. Give me a moment. Can you see the screen?
Yes, sir.
Okay. So today, first of all, thanks a lot for inviting me for this, and really sorry for not giving that article for this program because of some other personal reasons and the schedules here. So today I'll be talking mostly on sacrohysterectomy, just focused on mostly on the fixing of the uterus, that also to the posterior, rather than focusing on the entire prolapse surgeries as such. First of all, let me thank Dr. Tamal Selvi for giving a very good overview of the anatomy, which has made my job extremely easy. So it's very important when you deal with these kind of patients to understand the concept of prolapse, why it happens. We all used to say that from our postgraduate days, it's all about pelvic floor, and it's not about pelvic floor at all. The function of the pelvic floor muscles as such is very less, very less, just 10 to 15% in keeping the pelvic organs in place. It's all about the fascia of the pelvic floor and upwards, which keeps the pelvic organs in place. If you look at the pelvic floor also, if you see when we used to dissect the patients with pelvic floor prolapse, they dissect the muscles down in the pelvic floor, we dissect the levator tranae. I have never seen in my life a stretched levator tranae. I have always seen that the levator tranae splits in the middle. In the middle, levator tranae is actually kept together by fascial connection, not by muscular connection, but just facial tissue. And that tissue splits in the middle, and that is the reason where the levator tranae supports goes. or it gets levator gets detached from the lateral obturator arcus tendinous, which is again a fascia. Arcus tendinous is a fascia, condensation of fascia, obturator fascia, which extends from the pubic symphysis to the ischial spine. So I actually do not believe it's something to do with the muscles actually. Of course, for mild cases and all, you can do all the muscle trainings and all those things. But pelvic organ prolapse is all about having proper facial integrity, facial structure, and the ligaments which are supporting the pelvis. If you see the uterus which is kept upwards, two things are keeping the uterus upwards. Number one, again, the pelvic floor. The pelvic floor, because the uterus and the vagina goes horizontally, it's, if you see the anatomy as Dr. Tamil Selvi has shown, the entire pelvic floor is, entire vagina and the uterus are actually lying on the pelvic floor. It's just lying on the pelvic floor. And if you keep it vertical, then you can see the pelvic floor doesn't have any role in the supporting. Because the vagina is horizontal, it actually lies on the pelvic floor, in the central part of the pelvic floor. And that is why the pelvic floor support. The moment the central part of the pelvic floor gives away, which is actually a fascia, you find that the vagina will start collapsing. And same thing with the uterus. It is just held by the uterosacral and the Mackenrosh ligament. And these are not anterior ligaments. These are mostly posterior ligaments. As again in Tamil Selvi's talk, I was noticing that she specifically told you need to correct these ligaments, whether artificially or naturally. These ligaments have to be corrected, which goes completely in favor of a posterior fixation of the uterus. So these are the concepts which I want to make it very clear. And if you look at the methods of correction, you have anterior methods, you have posterior methods, you have the vaginal methods. All these are basically facial corrections. Either you correct the fascia or you duplicate the ligaments which are already there. None of this come in the muscular correction. We are not correcting the levator in any of the prolapse surgeries so far. We are not even bringing the levator together. We are not tightening the levator. None of these surgeries depend on the muscle correction. It is always a facial correction. Now, the problem of facial correction, if you depend only on the facial correction, basically what happens is, these are all, see, we used to believe that it is facial trauma, but it's not really facial trauma. We have been operating on multiple ethnic population. We have seen that its basis is a genetic defect of the collagen in the fascia, and that leads to the prolapse, or that leads to the lesser integrity of the fascia and prolapse of the pelvic organs. And this can, of course, be supported by the multiple birth traumas or whichever trauma which happens to the collagen. But those patients who doesn't have this inherent defect, even in spite of multiple birth traumas, they do not really prolapse. We have seen these Arab patients who have 15, 16 vaginal deliveries. They do not really prolapse even after so much of vaginal deliveries. But in our Indian patient, they start prolapsing much, much earlier. And it's basically the defect of the fascia. So this facial corrections, if you are doing, understand that you are correcting a defective collagen again and again, and the chances of recurrence are higher. That is why we need to have something more to the facial correction. And now here are different methods. We have the anterior method, where Purandra's sling was there, and something similar to Purandra's sling is the Sunrise anteroposterior sling. Then you have the pectopexy. We do not rely on the anterior methods now because it's completely against the anatomy. If you can see here, the anatomy, if you can see here, can you think, suppose this is a vault, actually you have the uterus here. Can you think of the uterus being fixed to the anterior here? This is the abdominal wall. If you fix the uterus anteriorly here, it's completely non-anatomical, and you can see that it is going to compress the bladder a lot, and more than that, it will change the direction of the vagina more perpendicular, more vertical, which will actually again lead to prolapse if you fix it anteriorly. So it has to be fixed posteriorly so that it lies on the pelvic floor. And the method of posterior fixation is always on to the sacrum, whichever way you fix, it is mostly onto the sacrum as such. That is why we usually prefer the posterior method, but at the same time, there are some cases where you have a larger cervical length which is formed by the prolapse of the uterus, especially in kinds of nulliparous prolapse. You find that the supracervical and the intracervical length can be very large, and whichever way you pull the uterus, you find a part of the cervix lying outside the vagina. In such cases, it is very important to do an amputation of the cervix, and whenever we do the amputation of cervix, we do the Fothergill's also. We take the Mechandrod's uterosacral and bring it anteriorly, as you can see here. This is actually a very good method, and it gives very good results actually in short-term results, of course, in cases of milder prolapse. When you bring it anteriorly, you can see that this uterosacral Mechandrod's here, if you see, the uterosacral Mechandrod's are brought anteriorly and then sutured. It is detached from the lateral and brought anteriorly and sutured. Then you amputate the cervix, and you can take this Stamdorf sutures. You can take the vaginal wall inside the cervix and bring it out from here and suture, tie it again here, which forms the infravaginal cone of the cervix, which is actually very, very important. Otherwise, what happens? It will be like a flushed cervix to the vagina if you do not put these sutures, Stamdorf sutures properly in most of the cases. Now, if you look at the anteroposterior sling, this was the method which we used to do for the anteroposterior sling surgeries. Can you see the video? Can you see the video?
Yeah, we can see.
Okay. So in these cases, what we do is, I'll just fast forward because this is not a method which we do nowadays. This is a little older method. You are opening the posterior peritoneum, and then you're bringing an artery forceps in the abdomen along the round ligament. You can see that it goes along the round ligament, this artery forceps, and comes posteriorly just above the ureter. It comes. It has to go above the ureter, as you can see here. As you can see, this artery forceps travels along the retroperitoneum, comes above the ureter, pierces onto the uterosacral ligament. You can see that it just pierces onto the uterosacral ligament, and it can be there can be a mesh which is fixed to the posterior part of the uterus, as you can see here. See, it pierces onto the uterosacral here and then pulls in a mesh outside. You hold on to the mesh and then pulls the mesh outside. And the same thing is done on the other side also. And both the sides, the mesh is coming out on the lateral incision, as you can see here. And then you put in an artery forceps in the plane above the rectus sheath to the other port and pull the mesh. So it comes like a sling. It comes like a complete sling and pulls the uterus upwards. We have stopped doing this procedure mostly because there is a lot of cases goes into a hourglass bladder. Whenever the bladder is full, as you can see here, whenever the bladder is full, you will find the hourglass kind of bladder, which will prevent the proper evacuation of the bladder. As you can see here, you can see the anterior compartment gets completely compressed as the uterus is pulled upwards. So this can actually create something like a hourglass bladder. The bladder goes above the uterus and it creates problem. But the fixing of the uterus is quite good in these cases. And we have started getting some cases of fistula and the tract of the mesh. So we completely stopped this procedure now. And today we are into a totally different procedure. Now, this is the procedure which I prefer nowadays. I don't prefer pectopexy at all for obvious reasons that it is an anterior fixation and it is fixing to the just maybe 3 or 4 centimeters from the vaginal introitus, which will shorten the length of the vagina completely and makes the vagina actually vertical, which can lead to more chances of prolapse. Now, coming to this posterior repair, as you can see here, this we call it as a Rahman's method. It's completely different from the usual Purandares, but something like a modified Purandares done laparoscopically. as you can see here, one of the most important thing in this method is the facial plane. See, as you can see here, every fascia, every viscera will have a plane, which will have a fascia. So you should not damage the fascia over the viscera. Like here, you will find the fascia on the sacrum is different. The fascia on the rectum is there. The fascia, there is a fascia on the vagina, and there is a fascia on the rectum, and in between these fascias, you will have a plane. So you have to keep the mesh in that plane, very clearly in that plane. As you can see here, this dissection is extremely important. Otherwise, you do all these mesh surgeries, you will end up in more and more complication, and you will ultimately keep blaming the mesh. See, here you can see that on the sacral promontory, you can see a fascia. You can see a fascia on the sacral promontory, and below that fascia, you can clearly see that the nerves and the vessels are going below that. Can you see the fascia on the sacral promontory? Below that fascia, the nerves and vessels goes. So you are doing a completely nerve sparing surgery basically by doing this, and a completely avascular plane. You can see the fascia over the rectum also is totally undisturbed. So this mesh we are going to keep is a titanamized mesh in this plane. Titanamized mesh, the advantage is it doesn't get adherent to the uterus. It doesn't get adherent to the rectum. It doesn't get adherent anywhere. It's an anti-adhesion coating. The titanium is actually an anti-adhesion coating. So we call it as a dynamic sling. So this is basically a dynamic sling which we are keeping. If you do an ultrasound post-operatively, you will find that the rectum moves over the mesh. So whenever a tissue moves over another area, there is very less chance of erosion of that mesh into the organ, into the viscera. So that is the advantage of this method, where you can see that we dissect down up to the levator completely, and you can see that we are going in the exact plane between the rectum and the vagina. You can see there will be a fascia over the rectum, and there will be a fascia over the vagina. So this is the two layers of the denovillous fascia. Can you see that plane opening up? You can see the fascia over the rectum, and you can see the vessels over the rectum very clearly. Now, most of the workers, we have seen that they just fix the posterior part of the cervix and sling it upwards, which is actually not at all a correct method. If you are doing a proper repair of this prolapse, you need to repair the entire area. So these cases, you have to go down up to the levator. This is a titanamized mesh, which you can see up to the levator, so that it clears completely the cystocele, rectocele. Otherwise, what happens, there will be a bulging of the rectum and the rectocele. Later on, the uterus alone will be kept upwards by the slinging of the mesh, and you will have a bulging rectocele and cystocele. So in these cases, you go down up to the pelvic floor, fix the mesh there, then come upwards and then fix it to the sacral promontory. Now you can see one thing, that we are fixing the mesh very loose to the sacral promontory. It's not that the mesh is pulled up and kept. It's not the mesh which will be pulled up. It will be the uterus which we are going to pull up and keep. The mesh is kept loose so that the movement of the rectum is very smooth. The moment there is enough space given by the mesh for the movement of the rectum, and I usually fix it on to the sacral promontory and not to the anterior longitudinal ligament. I find it much more convenient to do that with this ProTac. We use 1 or 2 or 3 ProTacs. You have to be extremely careful that you are using a new ProTac each time, or a properly sterilized. It should not be sterilized in Sidex, because one of the complications which you can face is sacritis, which can be a little bit of a problem. Then what we do is to sling the uterus up. See, previously we used to fix the uterus posteriorly onto this mesh. What happens is, many cases it cuts through posteriorly. When you fix it, it cuts through, and then the uterus mesh will be there, but the uterus will collapse again. So here you can see a muslin tape is taken, and then you can see that it is taken to the mesh, and the muslin tape will sling on the mesh, and then you can see that this needle will go through the other side like a cervical encerclage. So the cervix is completely encirclaged by the muslin tape, completely encirclaged, and this muslin tape comes and fixes onto the onto the mesh. So that way, there is absolutely no chance of this uterus going down again. And there is very less chance of having a rectocele when you do with this method. One of the problems of this method is again the anterior compartment. Any posterior compartment fixation, the biggest problem if you overstretch the uterus is stress incontinence. And what will you do if there is a combined cystocele? In cases of combined cystocele, in these cases, most of the cases we have seen that it is usually a paravaginal problem. It's a paravaginal problem. And you can see how it goes up. You can see that the rugosity of the mucosa has to be maintained as much as possible. If you are maintaining that rugosity of the mucosa, you can be sure that you are not pulled it too much. If you are keeping the mucosa very smooth, be sure that you will get into a stress incontinence, and it can be a little of a problem later on. Sorry. So one of the biggest problem is this mesh, whether the mesh is the ideal thing to keep or to keep something else. We are always searching for a better material to be kept on the in this area. And one thing which you have seen is to take the posterior rectus sheet, like we used to take the fascia lata. You can take the posterior rectus sheet because above the umbilicus. Because above the umbilicus, there are two rectus sheets. There is no chance of hernia if you take the posterior rectus sheet alone. So this posterior rectus sheet can be taken, and it can be formed quite wide like a mesh. As you can see here, you can cut this posterior rectus sheet and use it instead of the mesh, which we have to have more number of cases on this to comment on it. We just started doing it. So you need to take this posterior rectus sheet, and then you can keep it in place of mesh, and it should work much better than, you can see the sheet. Actually, it's a very nice material, and it can get blood supply once you take it onto that area. As you can see here, you can get a good material once you take the falciform ligament upwards, and you can take it down and fix it in the area of the mesh. Now, there are certain inherent problems with this kind of a repair, not exactly complications, but I would take it as inherent problems. One is constipation. Some of these patients, if you are not really doing a nerve sparing surgery, and if you are not keeping enough space for the rectum to move, these patients get into constipation. And this constipation, if you damage the nerves, usually it stays for almost 6 to 7 months, even for 1 year. You need to treat the constipation in these patients. If they get into, initially when we used to do the surgeries, we were not in the right plane. We used to have constipation almost up to 30-35% of the patients. But nowadays it has been reduced to almost less than 5% of the patients, because we are able to get into the correct plane where we can keep the mesh, which doesn't get adherent to the rectum. Another problem is stress incontinence, or it's incontinence. Stress incontinence, which is another problem when you pull the uterus too much high, which will straighten the urethral ankle, and this can lead to problems. So avoid pulling the uterus too much high. And if you feel that the patient can go into a stress incontinence, you can even go for a TVT tape, or you can go for a Birch Colpo suspension. If you are not in for the patient is not willing for TVT tapes, as many patients today are not willing to put in the TVT tape because of obvious reasons. Now, as complications of this mesh procedure, you can have mesh infection. Be very, very careful about having mesh infection, because if you get into mesh infection, it can be a little of a problem. Luckily, we have not had mesh infection so far, but we have sacritis. Initially, long back when we were sterilizing this stacker in Sidex, never sterilize this stacker in Sidex. You have to have a proper sterilization method for this stacker. So because we were using the stacker, when you sterilize in Sidex, you can have infection, and it can be very difficult to treat it. But mild sacritis you can treat with antibiotic or of course anti-inflammatory, and these are diagnosed by doing a CT scan, and you can clearly diagnose sacritis. Mesh erosion. Mesh erosion is not much of a problem in our cases because of the correct plane of keeping the mesh as such, and we do not have much problem with mesh erosion. But it can happen if at all you are not in the correct plane and you are exposing the muscle layer of the rectum or the bladder or the vagina. If you are exposing the muscle layer, the mesh gets adherent onto the muscle layer, the muscle contracts and then pulls in the mesh over a long period of time, and that is a basic reason for mesh erosion. If you keep it in the correct plane, if you keep it between the fascia, then the rectum doesn't get actually adherent, especially if you are keeping mesh or the titanomized mesh, and the chances of erosion are much, much lesser. So it's very important as conclusion to understand why this collapse occurs, and it is not about tightening the muscle only in cases of prevention of prolapse. That is prevention of further progress of prolapse. We can use muscle strengthening or pelvic floor exercise. Once the muscle is torn in the center, there is absolutely no more role for strengthening the muscle. So it's all about fascial strengthening. To understand, it is not just two ligaments which hold the uterus upwards. There are multiple ligaments. As Dr. Tamal Selvi was telling, the entire fascia is holding, and in between there are certain condensations which are holding the uterus and the vagina upwards. The main two condensation, I understand, it's a uterosacral Meckenroth's ligament, but there are plenty of condensation. We are just investigating into where all you can find the condensation. When you dissect the fascia, you can see plenty of condensation here and there. Basically, we have seen a good amount of condensation in the mid-urethral area. When you dissect the anterior bladder area, mid-urethral area has a good amount of condensation of fascia. There is good amount of condensation of fascia in the lateral upper part of the urinary bladder. There is good amount of condensation of fascia where the cervix comes in contact with the bladder. That is a lateral part of the cervix where we call it as the bladder pillars. There is good amount of condensation when the vagina gets onto that levatrine. There also we have seen this kind of small ligaments which are forming of the fascia. So it's not just two ligaments, it's the entire facial planes which keep the structure straight, including the urethra, including the rectum, as well as the vagina and the uterus. So thank you so much for all your time. I hope you enjoyed this.
Excellent, Dr. Hafiz Rahman. That was a wonderful demonstration. Thank you very much. I think we have a few questions. The first question is from Dr. Tamar Selvi. Excellent demos, Hafiz sir. It's just that you're not fixing the mesh to the posterior surface of the uterus or to the vagina. Vaseline tape at the level of the cervix can prevent uterine prolapse, but what about rectocele?
Yeah, see what we are doing for rectocele is we are taking the mesh right up to the levatrine. The rectocele usually occurs above the levatrine. You do not have a rectocele below the levatrine. Most of the rectocele will occur above the levatrine. So you are having a mesh between the rectum and the vagina, which completely prevents the rectocele. Otherwise, in many cases, if you just pull the cervix, if you just attach the mesh onto the cervix and pull it upwards, as many workers do who do not want to dissect it up to the levatrine, there can be a rectocele later on. So here, there is absolutely no chance of rectocele. We have done quite a good number of cases by now, and we have never had a rectocele post this.
Sir, I have a few questions. What is the landmark at which you harvest the rectus sheath? You showed a video of the rectus sheath.
Mostly we take it on the right side. We start at the level of umbilicus. We take the falciform ligament. Completely we cut the falciform ligament up to the liver. Then we take from the right side of the patient at the level of umbilicus, because at the level of umbilicus is where the rectus sheath stops, the posterior rectus sheath. At that level, we take it upwards. See, you should take at least 3-4 centimeters of rectus sheath, Because when you remove the rectus sheet, you will find that it is only, if you remove 4 centimeter, it will become almost 2 centimeter when you cut it off. So that much width you have to take up to the, we should not take beyond the ribs. The moment you reach the rib, you should stop it, because what happens is beyond that, it's a diaphragm. You will not even know. Diaphragm is a very thin structure. You can easily perforate the diaphragm. So you have to be very careful when you take it. So mark the area where you get into the rib area. So stop the sheet harvesting at that point.
Okay, and the width is 4 centimeters, but length
depends on the patient.
Okay.
Because
So,
it depends on the height of the patient.
if you're going to suture that rectus sheet onto the sacrum, are you going to use Protrac or are you going to use Ethibond kind of Protrac? Okay, and you showed us the Mercelin tape for the anterior and the mesh for the posterior. It's similar to that Oxford method where you can either make a T-shaped mesh, isn't it?
Yes, something similar to that. But the problem of T-shaped mesh is most of this T-shaped mesh goes lateral to the uterine artery.
Yeah.
Here I'm taking the Mercelin tape because it has a needle medial to the uterine artery. That's the difference. So it's a lateral to the uterine artery goes the T-shaped mesh, and medial to the uterine artery, our Mercelin tape will go.
Oh, literally hugging the uterus.
Hugging the cervix. See, like cervical answer clutch. This Mercelin tape will be equivalent to a cervical answer clutch stitch.
Okay, that's the
only problem of this procedure. See, previously when we used to do this procedure, posterior fixation, we used to allow the patient for normal vaginal delivery. They do not collapse again, because in vaginal delivery, the cervix is taken up rather than pushed down. Cervix gets taken upwards rather than pushed down, so they can be allowed. But when you take the Mercelin tape around the cervix to prevent cutting off from the posterior cervix, you have to go for a C-section. So we need to counsel the patient before we do this procedure that you need to go for a C-section.
Have you seen any bladder problems after this? Because
we do not keep much of anterior mesh nowadays. Not because I had bladder problems, but I'm not very comfortable with this anterior mesh somehow. Previously, what we used to do is we used to dissect the bladder down up to the arcus tendinous laterally, and then keep the mesh right up to the arcus tendinous. Nowadays, what we are doing is if there is a cystocele, we dissect above the bladder, go into the space of ischias, put the bladder down and dissect the arcus tendinous, then we fix the paravaginal defect.
Okay, rather than
can be nicely prepared and then do it. And if it is a central defect, I would prefer to do a central repair like our usual anterior colpora.
Vaginal.
Here, somehow I'm not very comfortable with the mesh on the bladder.
And if you're using the rectus sheath for the sacrohysteropexy, would you retroperitonealize it just like the mesh?
Yes.
Yeah. Okay.
It's actually a dead sheet, no? It's not a live sheet, but it takes in vessels.
Thank you, sir. Thank you. That was very clear. Thank you very much. Thank you very much.
Your video presentations are very good.
Very clear.
Very clear.
Thank you, sir.
Thank you so much.
Thank you, sir.
Excellent presentation, sir. Hafiz, sir. Good afternoon.
Can we have the introductory slide for welcoming Dr. Mala Raj, please? We welcome our own Dr. Mala Raj. Very proud and happy to have her here. She does not need any introduction. However, she is the founder secretary for Tamil Nadu chapter for the IH, managing council member, executive committee member of OXY, past secretary of IMS Chennai chapter, and had a training in advanced endoscopic surgery in Strasbourg, China, Strasbourg and China. She is a trainer for FOXY and ICUG recognized training center for endoscopy, accredited menopause practitioner, and has been receiving various awards, including the Best Doctor Award, Best Video Award, and operating faculty in various conferences, authored many chapters in various textbooks, and currently managing director for the firm hospitals. So welcome Dr. Mala Raj, and we request her to deliver her talk.
Yeah, thank you so much, Dr. Meera Raghavan, for the warm introduction. So, of course, it is very, very difficult to talk after a legendary talk by Dr. Hafiz Rahman. It was really excellent and mesmerizing, in fact. But then we all know laparoscopic sacrocolpopexy and hysterocolpopexy is the gold standard in the treatment of prolapse, be it the wall prolapse or the intravaginal prolapse. But you need to have the hands of Dr. Hafiz Rahman, and also you need to have the knowledge and the skill of Dr. Hafiz Rahman to perform such an excellent surgery like this. Wherein invariably what happens with sacrocolpopexy is that, as Sir mentioned, in most of the people, like they fix the mesh only onto the cervix, posterior side of the cervix, and also the mesh is fixed in superficially. So wherein the problem occurs of erosions and also damage to the hypogastric nerve. But when with Sir's technique of nerve sparing, hypogastric nerve sparing technique of sacrocolpopexy or hysterocolpopexy, the outcomes are really excellent. So we all know that is the excellent and gold standard. But then when there is a plan A, there is also have to be a plan B. So we have this plan B, which is a laparoscopic pectopexy, wherein in certain scenarios when you are not able to do the sacrocolpopexy, we can do a laparoscopic pectopexy, which is a relatively a simple procedure, and it is more, it has its various advantage as well, which we are going to look at. So to start with, I would like to quote Hippocrates, where there is two things in life, that is science and opinion. The science begets knowledge, the second is ignorance, and we are also going to now see what science is, and all of us truly believe only in science. So there can be many opinions though. And of course, when it comes to prolapse, it is really a complex condition, because one needs to really totally understand the prolapse, as it has been beautifully highlighted by our guest of honor, Korean sir, and of course, Dr. Tamal Selvi has also highlighted beautifully the anatomy of prolapse. So we need to understand what exactly is the type of prolapse, so that we are able to decide on what kind of treatment protocol we need to offer these. So various classification has been coined by various authors, but then what has really now stood the test of time is only the POCU's classifications. Of course, Baden did come in and he suggested a kind of classification which was easily, it is quite useful for our clinical practice. But then when we as gynecologists, we are examining a prolapse patient just for research purpose and also for documentation, the POCU classification has stood the stress of time. And of course, now, in fact, POCU also has come out with an app where people can enter the grading on the app and come to a classification. So this has been beautifully highlighted by Dr. Tamal Selvi, the Delancey's support. So when one is handling a prolapse case, we need to definitely understand the supports of the uterus, wherein just a few points where I would like to highlight is definitely this 3 level of prolapse, that is the level 1 support, where the lateral attachment is mainly the uterosacral ligament and the cardinal ligament, which is mainly responsible for the apical prolapse when the defect occurs here. And of course, the level 2 is mainly by the vaginal lateral wall, which is attached to the fusion of the urogenital diaphragm and also to the archinus tendinous above. And lower level 3, you have the attachment is mainly the perineal body, and the the level 2 is mainly by the arcus tendinous and to the pubococcygeus and the ischiococcygis, and the level 3 would be you have the urogenital diaphragm and the perineal body, that is in the lower half of the vagina. So when we have a prolapse, like the wall prolapse, when we have a quantification like this, of course, we have the pectopexy, which plays a very major role in these kind of prolapse, because here we do not change the axis of the vagina. We are able to fix the wall onto the iliopectineal ligament, and the axis of the vagina is maintained at S2. So of course, when we have various kind of treatment for these apical prolapse, like the vaginal sacrospinous fixation and laparoscopic sacrocolpopexy, and also laparoscopic pectopexy, which has come as a new kid in the market. So this, when we do a sacrospinous fixation, the basic disadvantage is that the angulation of the vagina is altered, wherein it is fixed to the almost there is 45 degrees deviation. So because of this, what happens is that you have a defect on the opposite side, the left paravaginal defect. So to overcome all those things, we have the sacrocolpopexy. But of course, sacrocolpopexy has its problem, like the back pain, the sciatus, bleeding, and also the bowel symptoms, because the pelvis is quite constricted because the mesh is going through the pelvic cavity, and also the stress urinary incontinence, because the mesh is fixed posteriorly. There is a defect on the anterior compartment, and as a result, the women can have stress urinary incontinence. And also, when there is damage to the hypogastric nerve, you have defecation disorder, and mesh erosion is also quite common if it is not done properly, and if it is fixed very superficially above the not below the face, above the fascia. So these are the few drawbacks of the sacrocolpopexy, wherein the sigmoid is retracted to the left, and thereby this allows the identification of the sacral promontory. So sometimes in obese women, we have difficulty in identifying this sacral promontory, and so also we need to take care of the sigmoid, the presacral veins, and also the right ureter. So accessibility to the surgical site at the ventral side of the sacrum also is sometimes quite a challenge. So to overcome all these problems, of course, so people modify this technique and fix the mesh to the promontory, and this change of mesh location results in the positional change to the direction of the anterior abdominal wall. So these are the problems encountered, and as a result, there are many urinary dysfunctions encountered. So to overcome this problem, we have this latest technique called the laparoscopic pectopexy, wherein we fix the apex of the vagina to the iliopectineal ligament. We are not fixing it anteriorly, it is going laterally. So just as a result, there is no deviation of the angle of the vagina. So of course, anatomy, we all now truly understand, it is just not the muscular support, it is the fascia which is mainly responsible, and we need to ensure that we take care of that fascia. So here, this is a case of a vault prolapse, wherein we are doing a laparoscopic pectopexy. So here, the basic first initial step is that we need to identify the iliopectineal ligament, for which the peritoneum is opened on the lateral pelvic wall between the lateral umbilical ligament and the round ligament. So you make an incision on the peritoneum lateral to the lateral umbilical ligament. So that gives us a clear idea where exactly the iliopectineal ligament would be. So this is the most important. This is the most important tip for us. We need to open it at the right spot so that we can identify the iliopectineal ligament. So many times when people do not get this landmark, that is when they find it very difficult to identify the iliopectineal ligament and fix it elsewhere. So invariably, this iliopectineal ligament, above that you will have some amount of fat, and also most of these patients are quite, it is done at a later age of life, so there will be quite a lot of fat. We have to remove all this fat and create the iliopectineal platform for the iliopectineal ligament. And at the same time, we also need to dissect the bladder and the rectum. So the bladder is dissected anteriorly and the rectum is dissected posteriorly. So we have to place the mesh on the vault so that we are creating a platform for the fixation of the mesh, and then you are dissecting the fascia and separating the bladder well away and also the rectum posteriorly. So once this platform is nicely created, and then we are fixing the mesh. So here you can see that the stitch is now being taken on the iliopectineal ligament. We use the we fix the mesh to the iliopectineal ligament by taking just 1 or 2 bites, and you can see that the mesh is of about 15 centimeters in length and 3 centimeters in width, and you can just fix it with number 2 absorb sutures, and then once the sutures are fixed nicely or laterally, then you can take the stitches in the central portion. So again, here you can see that the mesh is now fixed to the opposite iliopectineal ligament, and then once this is done, and then you can fix it centrally onto the vault. So the most important thing is we have to ensure that the sutures do not go into the vagina, so that there is no erosion of the mesh. So this is on the opposite side where you are taking a bite on the pectineal ligament and onto the mesh. So generally we use a macroporous mesh to prevent any kind of mesh erosion. So once this is fixed, and then the uterus, the vault is nicely in its normal anatomical position, then we need to just trim the redundant portion of all the mesh and then suture the peritoneum, thereby covering the entire mesh. So they are taking few more bites on the mesh and anchoring it. And once this is done, we cut the redundant portion and suture the peritoneum. So in no way the basic advantage is that the mesh never comes into the pelvic cavity at all. It goes very laterally. It doesn't go anteriorly, it goes laterally. So as a result, you do not have any kind of defecation disorder, and also you do not have any kind of urinary discomfort. So, of course, this is what we all understand. Having understood the anatomy, and only when we understand the anatomy, we can do the prolapse surgery efficiently. So, as beautifully Hafiz sir has said, it is not just the muscle, it is the fascia. So, all this interrelation of all these things, integrity makes the holds on to the uterus in its normal anatomical position. So sometimes we can also do a pectopexy in case when we are doing a TLH procedure. But the most important here is again the iliopectineal ligament, which is being opened. And again, as I said, the landmark of the iliopectineal ligament is very important. The iliopectineal ligament is found to be much stronger than that of the anterior longitudinal ligament, which is being used for sacrocolpopexy. In fact, they have done a study wherein they have fixed a mesh onto the, while fixing the mesh to the anterior longitudinal ligament, they found that the anterior longitudinal ligament was only 1.4 centimeters thick, whereas the iliopectineal ligament was almost 4. So as a result, they found that iliopectineal ligament was a lot more thicker than that of the anterior longitudinal ligament. So that is the reason it is much stronger and it's able to hold on the mesh nicely also. And also we have a good platform wherein we can take the entire, utilize the entire iliopectineal ligament for anchoring the mesh. So here you can, after anchoring the mesh onto the vault, then you have to anchor the mesh onto the iliopectineal ligament. So here you can see that the iliopectineal ligament, the most difficult thing is that here the angulation of the needle may be a little bit tricky. So you have to get used to that angle, which would come in due course of time, to take a bite on the iliopectineal ligament, and then you have to fix onto the mesh, and just 2 or 3 bites is all that would be sufficient to hold on to the mesh. So the angulation is the most critical factor in case of the laparoscopic pectopexy, because we have to take a bite at a certain angle in case of this particular surgery. So once this is done, then you can fix it to the mesh in the, fix it to the vault. But most important thing is, while you are using the mesh in the vault, always ensure that the vault is closed nicely, so that with the vicryl and not with any other sutures like barb sutures, because if the barb sutures are being used, then there is a fair chance for the mesh to erode, because while manipulating the vault for fixing the mesh, there is a chance that the vault can open up, and there is a fair chance for the mesh to erode. So you have to ensure that you always, you fix the, suture the vault with only vicryl, and finally fix the mesh onto the vault, and then we have to just cover up the mesh with the peritoneum so that there are no exposure of the mesh. So here, as I said, there is the vital structures are not coming anywhere in between the mesh. That is, the ureter is well away from the mesh, and the hypogastric vessels are well away from the mesh. So as a result, there is no injury to any of those structures. And also the chance of erosion to those structures are also invariably less. So these are the basic advantages. And also here you are able to maintain the normal vaginal axis, because the normal vaginal axis is at S2 and the iliopectineal ligament being at L2 is a better site for anchoring these measures for these kind of repair. So this is the thing. And also sometimes, as it's been discussed, laparoscopic rectopexy in case of nulliparous prolapse. So of course, it is, as we discussed, it is not the muscle, it is the collagen which is mainly responsible for the strength of any tissue. And in nulliparous prolapse, most of this time, these women will have connective tissue disorders. That is because of their weak collagen. So in such a case, again, there is no point using any other technique but to use a mesh to fix these kind of prolapse. So this is a case of a second degree prolapse wherein the mesh is being prepared. Here, she also had a cystocele. So we are making a tongue shape, extension onto the mesh, so that it also takes care of the cystocele. This is a basic advantage, because any concomitant cystocele can also be corrected. But only drawback is sometimes, because we are correcting this, there is a chance for the rectocele, that is a posterior compartment defect, can occur, as rightly said by Hafiza. But in a scenario when we are anticipating there is a defect in the posterior compartment, we can do a Meckel's caldoplasty, and you can also plicate the uterosacral ligament, thereby preventing the posterior compartment defect. So you can fix the mesh centrally like this and take care of the cystocele also, and also fix it to the laterally to the iliopectineal ligament. So here you are fixing it to the iliopectineal ligament and on either side. So this is on the opposite side where you are fixing to the iliopectineal ligament. And finally, you can make sure that the uterus is brought back to its normal position, and the entire mesh has to be now covered it with peritoneum. So this is the basic advantage. As I said, there is no exposure of any of the vital structures to these mesh, and also the mesh is beautifully covered. So, the protective, it is also protective against lateral and anterior defect cystocele because of the lateral placement of the mesh in this particular technique. And why at all is iliopectineal ligament is mainly because of its various advantages, because it is found to be quite stronger, and it also, you have a wide platform wherein you can hold on to the, take a bite on the ligament, and also it facilitates reconstructions of the pelvic floor. And as I said, it is situated at the S2 level, so the optimal physiological axis of the vagina is maintained. And S2 is the anchor point for the physiological axis of the vagina, which has been studied. So the major advantage is that it corrects the anterior compartment. If there is a concomitant posterior compartment defect, we need to address that as well by doing a mechanocaldoplasty. And also there are no vital structures like the ureter, the hypogastric nerve, which comes in contact with this mesh, and relatively an easy technique to perform, and also no bowel complications because it does not come anywhere near the bowel as well. And then the de novo stress urinary incontinence also is not there, and there is no de novo defecation disorder either because there is no damage to the hypogastric nerve. So however, one needs to be very precautious about these vital structures, because while taking the bite on the iliopectineal ligament, if you're not very clear about the anatomy, you can encounter damaging between the obturator vessels and also sometimes the external iliac vessel, because while the iliopectineal ligament is just medial to the external iliac vein. So if your dissection is not appropriate, then you can damage this vessel. And also we have the corona mortis, which is the connection between the external and the internal iliac, which can also bleed. So all these things we need to keep it in mind before doing this procedure. So many a times to make the procedure even more easier, can we use tacker is what was a question. And people have also tried tackers, and this is a case where I use tackers just to know how exactly tacker is going to work. So here again, the same procedure of opening the iliopectineal ligament. Tackers are really relatively easy to use, and here, but here I used absorbable tackers. So here you can so here you can see that the iliopectineal ligaments are opened, and then the mesh is now going to be fixed to the iliopectineal ligament with the tacker. So the basic advantage of the absorbable tacker is that it does not remain in the body. So it takes almost 90 days for it to be to get absorbed. So that is the reason we use absorbable tackers compared to that of the titanium. So that it does not cause any other complications, and also it gets absorbed within 90 days. So you can use tackers. The tackers makes your job even more simpler. But the most important thing what one needs to keep in mind is the cost. So it is not very cost effective. So I prefer to use a suture. Just wanted to try how the tacker is going to work for this particular lady. So here I have used tacker, but it makes it a lot more easier because the mesh also does not get folded on itself while you are using a tacker. Unlike your suturing, wherein you have to make a constant effort to make sure that the mesh is not getting twisted. So these are the basic advantages where we can use the tacker, but finally on the wall we have to only suture it, and there's no room for any tacker onto the wall. So finally the mesh is getting covered and we are peritonizing it. So tackers have various advantage. Of course, as I mentioned, the pectineal ligament is thicker than that of the anterior longitudinal ligament. And so the mesh is fixed to the pectineal ligament between the pubic tubercle and the external iliac veins, and the ligament is 4 to 5 millimeter thick in this particular area compared to that of the anterior longitudinal ligament. So that is the reason iliopectineal is getting preferred now. And also whether to use tackers or not. So as I said, there is a study wherein they identified the thickness of the anterior longitudinal ligament, which was about 1.9 millimeters, and that of the that is iliopectineal ligament was about 3.9 millimeters. So as a result, they felt it was much better to use the iliopectineal ligament. And also which mesh is better. Of course, we all know the macroporous mesh is only better than that of the microporous mesh because of its various benefits. So how can one prevent mesh complication is that we always have to keep the fascia with the vagina. Of course, strict asepsis, never introduce the mesh through the vagina. And it has to be a tension-free repair. It has to just keep lying onto the vagina, onto the uterus or the cervix or whatever. And there should not be any tension on it. You have to use the optimum use of the mesh, avoid vaginal opening, and also pre-operative counseling. So, but we can use it in case of TLH, provided you do not introduce the mesh through the vagina, and also make sure the vagina is meticulously closed. So various articles on laparoscopy pectopexy by Gunter, wherein he had done a study and found that this is much better because it avoids all the post-operative de novo defecation disorder and urinary disorders. So to conclude, laparoscopy pectopexy, of course, enables the surgeons to use a wide area in the pelvis, and it does not compromise on the pelvic space, and also the post-operative complications are relatively less, and recurrence also is relatively less, does not change the direction of the physiological axis of the vagina because it is at the S2 level, and it is far from the very vital structures like the ureter, intestine, and the sigmoids. So thank you so much for the patient listening and for the opportunity.
Thank you, Mala. It's a very wonderful presentation. We're just wondering the way the mesh is being attached to the pectineal ligament, the alternative to sacrocolpopexy. Actually, you have shown the wide, with the hysterectomy, wall prolapse, and also with the uterus intact. It was a very wonderful presentation, and it was actually you have shown in the presence of cystocele, you can even have a T-shaped mesh where you can correct the cystocele repair also along with this pectopex, which was a wonderful thing. But is there any chance of erosion you have encountered in such cases?
Yeah, so to avoid erosion only, madam, you have to fix it properly onto the fascia and also ensure that the peritoneum is also properly covering the entire mesh. We should not expose the mesh at any point of time.
Thank you, Mia. It's very wonderful. No questions.
Can I have some discussion on this?
Yes, sir. Yes, sir.
Yeah. Mala, see, this mesh, once you fix it, what is the relation of this mesh to two structures, that is round ligament and medial umbilical ligament?
Yeah, so this round ligament.
Medial or lateral to these structures?
Yeah, so these are lateral, sir. So
lateral.
The lateral to which structures, sir?
Median umbilical ligament and round ligament.
Okay, so lateral, that is, it is lateral to the lateral umbilical ligament, sir.
Median
it is lateral to the, not median, okay.
Medial to the median umbilical ligament and round ligament.
Median umbilical ligament, yes. It is lateral only.
Lateral to the median umbilical ligament or medial to the median umbilical ligament?
No, sir. Okay.
Lateral to the lateral.
We are opening lateral to the lateral umbilical ligament, sir. Opening lateral to the lateral umbilical ligament. Not medial to the medial umbilical ligament, sir. We are opening lateral to the round ligament. So it will be medial to the round ligament.
Because these two structures are going upwards anteriorly.
No, it is going laterally, sir. So we have the lateral umbilical ligament, median umbilical ligament, sir. We are not going anywhere near the median umbilical ligament. Lateral umbilical ligament, immediately lateral to the lateral umbilical ligament is the iliopectineal ligament, sir. So actually speaking, theoretically they say you open the peritoneum parallel to the round ligament and make an incision upwards so that you reach the iliopectineal ligament up to the level of the lateral umbilical ligament. But what ideally I felt, initially I tried that, but what ideally I felt in due course of time was, you don't have to do even all of that. If you just open lateral to the lateral umbilical ligament, you'll hit the iliopectineal ligament. So many a times if you open from the round ligament, that is when you make an incision parallel to the round ligament and go right up to the iliopectineal ligament, I find it a little bit tricky. So you have all the vessels coming up. But if you open immediately lateral to the lateral umbilical ligament, you can feel the bony prominence and you'll be able to identify the iliopectineal ligament easily, sir. So you can avoid the external iliac vein there. So that is
the problem. See, the round ligament goes anteriorly. It doesn't go laterally actually. It goes anteriorly onto the foramen.
Yeah, sir, to the canal, no, so it is going, but this is going even more, it is going lower down and also medial to the round ligament. So actually what you are saying is because it is lifting the uterus anteriorly, all those problems of ancestor. But ideally speaking,
the round ligament is the ligament which anteverts the uterus.
Yeah, so this is almost following the direction of the round ligament.
That is why I'm telling this mesh is actually fixing it anteriorly and not laterally.
I don't know, so but I sincerely feel.
Because laterally you have the vessels actually. See, laterally the fallopian tube goes, posteriorly the ovarian ligament goes, anteriorly the round ligament goes. So the mesh goes along the round ligament and fixes it anteriorly. Actually, it fixes onto the pubic arch.
Yeah, sir, but it is lower down, no, sir. It is a little lower down to the round
lateral, that's all, yeah.
Incision is going from the round ligament lower down. So at S2 means it is little lower down only, sir, and lateral, sir, very lateral. So that is why, sir, people, the patients are very comfortable with this, and it is relatively a less invasive procedure. Of course, it is, of course, with an expert like you, this is the best where you go right up to the perineal body, sir. Because I have seen you operate how you are doing. You go right up to the perineal body, fix the mesh, and then come up, and also you take care of the anterior compartment, all those things. In an expert hand like you, it is better. But if this pectopexy is a relatively simple procedure. Just with 2 or 3 cases, people are able to master it.
Yeah, it's a much easier procedure, no doubt.
And also complications are less and advantages is also there, sir, because the patients have been quite comfortable. They have done quite a number of cases now. So I don't have a very big, numbers like you, sir, but then I can see the difference in the patients. So our patients are comfortable.
Can we, any more questions? Can we move on to the next session because of time issues?
Thank you, Dr. Meera. Thank you, Prem.
Thank Hepsiba Madam, Chennai Menopause Society for giving me this wonderful opportunity. And Hafiza, thank you so much. It was just a treat to the eyes, your surgery and this presentation.
Yes, I thank both of you, Mala and Hafiza, for the wonderful video demonstration. It was very, as she said, it's a treat to our eyes.
Yeah,
thank you, sir. Thank you, Mala.
Thank you, ma'am.
Thank you so much to all.
Thank you, sir. Thank you, sir. Thank you so much.
New and posteriorly will.
So, Madam.
The next session 3, is by our international speaker and is chaired by Dr. Sampath Kumari, Chief and HOD.
Cystocele, a stage 3 cystocele with a little bit of a uterine prolapse.
Chief and HOD of Muthukumaran Medical College, and Dr. Hepsiba, our president. Over to you, Sampath Kumari, madam.
Thank you, Dr. Padma. Now we will have the session of topic with non-invasive management of POP and transuterine vaginal suspension by Dr. Red Allinson. Since he is having the connectivity problem, we can have the recorded message. So he had his medical training at Loma Linda University Medical Center at 1990, and he was the director and founder of South Coast Urogynecology and Allinson Institute of Aesthetic Vulvovaginal Surgery. He has procedures developed by him are the radio frequency surgical technique of aesthetic gynecology, in office RF labiaplasty, RF vaginal and perineoplasty, and Thermi O and O shot with AM drop amniotic fluid. He has many awards to his credit. Outstanding contribution to cosmetic surgery by International Society of Cosmetic Gynecology in February 17, and May 17 he had got Lifetime Award of Lifetime Contribution to Cosmetic Gynecology by European Society of Aesthetic Gynecology, and by July 2017 he has Best Feminine Rejuvenation Enhancement Aesthetic Show Las Vegas, and he had outstanding contribution of cosmetic surgery by International Society of Cosmetic Gynecology in April 2018. June 2019, ESAEG Master Course Faculty in Edinburgh and Scotland. In March 2020 and 2021, he had award for Best Result in Cosmetic Gynecology by the International Society. Now we can hear the recorded message of him for the 2 topics of non-invasive management of POP and transuterine vaginal suspension. Organizers, you can play the recorded message.
Yeah, thank you so much, Sampath Kumari, madam. I will play Dr. Red Allison's video. In fact, I would also like to add that, in fact, Dr. Red Allison has been my mentor for cosmetic gynecology. He's an excellent urogynecologist with great skills and hand. In fact, the most highlight of his surgeries are that he does all his procedures in the OP. In fact, he doesn't have a hospital. He has a clinic wherein he does even all advanced surgeries in urogynecology in local anesthesia. That's the biggest highlight. And we like to see now one of his surgery. I'm just playing that. Can you see this?
Yes.
Our case today is a seal, a stage.
Ma'am, now it is top shared, ma'am. We can hear one.
You can't see now?
Fix it
No, ma'am.
posteriorly with a dermal allograft called V-mu, and posteriorly we'll do it in a
Yes, ma'am. Yes, ma'am. We can see now.
plasty method. So that's what we have for today. So our patient has a
Ma'am, again stopped, ma'am.
to about 2 to 3 centimeters out when she's bearing down. She also
Only voice, Mala.
rectus seal here that's moderate right to the level of the hymen when she's bearing down. She has urethral hypermobility and stress incontinence. So we'll put a sling first. So first thing I'm going to do is put my hooks here to my Lone Star retractor. This is a Lone Star 8.
The video is not seen, Mala.
Oh, okay. 1 minute, madam. 1 minute.
With the Lone Star hook on it. And I'm going to just aqua dissect here a little bit on both sides. I'll put up to 30 cc's of this.
Is it seen now?
Yes, ma'am. Yes, ma'am.
With
I need to stop the ma'am.
Oh, if I enlarge it, this is going up. 1 minute, madam. I got it. 1 minute.
Okay.
Here's the clitoris. Go straight to the crease. Right here, level up the clitoris, right on the curl fold.
Okay, he sent it in a very different format. So to download itself also
right on the crease. Maybe this will work. A little mess and bomb here. That works okay. My mess work okay. Just expand the incision a little bit. Okay, a small mid-urethral incision right here. This is the mid-urethra right here.
Yes.
It's not able to enlarge it.
And I'll grasp it with my...
That's enough, I think, Mala.
Yeah, okay, madam.
See if I can dissect it a little bit more. And I'll use my medicine bombs to dissect laterally till I get beneath the pubic ramus. All right. There you go. I'm underneath the pubic ramus there. And I'll go on the opposite side. Okay. So I can reach under there. So here's the first transobturator hook. Going to go through the obturator foramen right here and come out to where my finger is. You'll push it downward, punch through the obturator.
So all this you're doing under local anesthesia, madam. Block.
Protect the urethra and the bladder, and then you come out right there. Okay, no buttonholing. Here, this way, same idea. You punch it with your thumb. Guide it with your index finger. Make sure you don't buttonhole. Go around the pubic ramus. I feel the tip now. And so now with my index finger, I'm going to guide that tip out right there. So here's that one. So here's the sling. You have to unroll it. So it lays like this. There's a notch here. You slide it on top, goes into the notch, and then you pull this through the obturator foramen, like so. Here's my tip, and grab my loop. I designed this system in 2002. And now Boston Scientific uses this system, and I think other companies use this system. Okay, it goes right through. Pull up. Here, you can have that. All right, now you get your 10 Hagar dilator, and you don't want to overcorrect. So I'm going to put that here. Remove this. And then I'll also free this up and make sure I don't overcorrect. So I'm going to hold it like this. This is a 10 Hagar, and then I'm going to remove the slack up on top. So there's a sling right there. Not over tight. There. 1, 2. And then actually, you know what? These just pull out. So these are 3-0 pop-offs. And I'll just do a few figure eights here and close this up. So I'm going to switch this down to here to grasp and give me some traction. That I have good traction and counter traction, so I'm going to use that as my first. Okay, so it's dissecting away. Sometimes just left dissection with my fingers once I get it started. So what I'm trying to do is dissect all the way down to the ischial spines. So I'm going to dissect laterally this way until I can feel the ischial spine. So that's where I'm going to put my sacrospinous ligament suspension suture. Use my bone star retractor to help with holding the edges open. Okay, now I'm going to go up the sides and I'm going to crawl up going this way. I can feel the ischial spines and I can feel the sacrospinous ligament. So that's our dissection so far. So I'm going to put that here. Okay, that's pretty good. There's the cervix, right? There's the cervix. So I'm right on top of the cervix now. So next thing we'll do is we'll use this Digitex device and grab the sacrospinous ligament I'll start on her left side. I can palpate the ischial spine and I'll go about 1 centimeter lateral to it. The bladder's protected. Firing, I hear that click, open, it clicks again. And it looks like I have a good bite. And then I'm going to make sure that I know where it is. I'm going to put it above this little loop. My index finger is on the ischial spine. I'm going to follow that index finger, and then I'm going to go right beside the ischial spine and go just slightly medial to it. I'm pushing now the tip of this device down into the sacrospinous ligament. I'm protecting the bladder, and then I fire. I hear the click. It clicks again, and it's anchored. Okay, so now we have our sacrospinous ligament sutures in place. Now I'm going to do the ones on the obturator. Another one, Digitex. I'm going to go in and go right to the obturator membrane, right over the obturator foramen. Turn it 90 degrees here, and then fire. So I'm going to grab obturator fascial tissue here. Click, come out. And this one goes above. Okay, this one goes onto the obturator. I go in, bladder's protected, turn it 90 degrees, push it onto that thick obturator complex, fire it. Also, so now we have the 2 obturators and 2 sacrospinous ligaments. Next thing, I'm going to put the sutures, the silks, right here, right above the cervix. So my finger is touching the cervix, but I want to dissect this bladder off the cervix just a little bit better. Push this out of the way so I can have a good place to tie down my silk sutures. So here's the cervix right here. I'm going to go ahead and put the first middle one right onto the cervix. And she does not have significant uterine prolapse. So I'm just going to place this one anchoring suture. If she had a significant uterine prolapse, I put another one on this side and another one on this side. But this is our dermal product, V-New, V capital N-E-W, V-New. It's a dermal allograft made by Arms Medical. It's the best dermal allograft available. It's adequately thick. And then my assistant will hold this up here gently like that. Well, these will go to the sacrospinous ligament and be attached to these sutures. And then these swings right here, that and that will be attached to these guys onto obturator. And right here will be attached to the cervix. So this is about the middle. Get a nice healthy bite right here. Go about 1 centimeter up, and that's where you place it, right in the middle. This way you don't get that band or a tightness at the apex or by the cervix. That can cause dyspareunia. So you want to give yourself a lot of space there. I have the most experience with dermis. We also used polypropylene, obviously, when it was available. All right, so this goes to the sacrospinous ligament here. This is attached to the cervix. That's going to go to the obturator complex. So right in the middle of it, I designed this so that if you just put it symmetrically in the middle, you're usually right 99% of the time. Right there. My original patent on this was called Sling with Bladder Support, and that was over a decade ago. So this has been upgraded in terms of design. Yeah, right here again, right in the middle. This way. Thank you, Matt. All right, so those go to the obturators. These go to the sacrospinous ligament. So when you do your suturing, tie the middle first. I'm going to tie this one down, and then I'll tie these, and then you tie those. So this is the first one. Here you go. I'm going to tie this right onto the cervix, and this will give us anchoring into the cervix and actually give us a little bit of a uterine suspension also. And I tie it away from the bladder. You notice I tie it on the dermal side, not on the bladder side. I'm going to go ahead and tie this and push it into the
Ma'am, video is stuck.
Not playing with Dr. Mala, video is not playing.
Oh, it's not playing, is it? Okay. Now, madam?
and then,
it's playing.
Yes. Now it is playing.
there. And I'm going to go ahead and push that down and then follow it with the suture. I like pushing that down first because I've had it where I accidentally tied it short. It got caught onto that wing. So push that wing first or that leg and then tie gently, nothing over tight. You don't want to constrict and cause a lot of pain and discomfort. You're basically tying almost an air knot here and then trim it short. I can see my tip. Okay, trimmed. And I'm going to do the same thing here. I'm going to push this down first. Push this tip right onto the sacrospinous ligament all the way down 4. The whole base is anchored. This will pull in a little bit. There you go. Opposite side. I'm going to push that in. There. It's wrapping around pretty well. Okay, let's take a look at how it looks so far. It looks like it's laying pretty good to trim straight across. This is the Allen Sod scissors, by the way. This is called the Allen Sod A1 scissors. It's made for pelvic surgery, urogyne, and notice the angles are perfect. You can always see the tips when you're working deep inside. So these are 2-0. Going to put it into the pubocervical fascia here. These are 2-0 vicryls. Or actually, I'm going to trim it so it's a perfect fit right here. So they'll fit perfectly on that side. And on this side, just a little trim of this edge. I'll secure this edge up to here. So I'm going to grab some of this and secure it to this edge. So here it looks like it tucks in very well. Here, you know what? I'm going to put one right there because pop-up, I see a little bit of this. So I want this to be secured. Pop-up. So I'm going to go ahead and grab some tissue here laterally and then secure it to this bit of dermis here. All right. All right, so there's excess vaginal mucosa. So what I'm going to do is I'm going to trim off the excess vaginal mucosa. And just enough on each side to give us a good snug fit to a monochrome, and I'll just run it. I don't want to watch this. All right. So I'm going to do a second layer. You can see that we were able to reduce that cystocele pretty good, but this layer right here, I'm going to do a little bit of imbricating of the edges with this monocryl so that I have a secure closure, and it will look, when it heals up, it'll look quite natural, like no repairs ever been done. And then I'm going to grab here. Got it that way. And then some on this side. And then while I pull on this, I'm going to push right here, like that, pull that. Okay, so I got rid of the cystocele, the uterus and cervix will be suspended. And then I'll feel, make sure we didn't reduce our length. Okay, so that's well suspended. All right. Got rid of the rectocele here and the cystocele. We have normal depth of the vagina and full length of the vagina. Close the transobturator surgical site on that side and this side. Go ahead and bear down and push. Push, 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 push. So nothing's coming out. Bear down and push. Push, 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 push. Okay, nothing. Relax. All right, bear down and push. Good, 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 good. All right, stop. Excellent. Let's take a look at the pelvic reconstructive surgery we just finished. From the gaping introitus and the bulge of the bladder, and also from the bulge of the bladder and the rectum, you can help these patients with their symptoms with a reconstructive surgical outpatient surgery nowadays. These are all done outpatient in my practice, and you can actually have them done with very gentle sedation. This is done in the surgery center, and you can see here we're able to get rid of the cystocele and rectocele, place a sling in, and help with the appearance. You can also reduce the diameter of the vagina to a 2-finger type vagina, and you can see here that it's much nicer in appearance. Now, this patient about a decade ago looked like this, and then after we did her surgery, she was much more normal in her appearance without these bulges. This is how it looked before surgery with the bulge of the bladder and the rectum. And a decade later, she came and saw me. The introitus and canal are 2 fingers tight, producing normal moisture, and she's quite happy with the procedure. Thank you very much.
Now one more.
Downside Institute for Aesthetic Global Vaginal Surgery, and we teach pelvic reconstructive surgery and aesthetic gynecology here on Laguna Beach. I'm the patent owner of several devices listed here, and these are disclosures below of the companies I actively work with. First of all, I have been doing teaching for aesthetic gynecology around the world, and this is my 18th year of teaching, mostly in Laguna Beach, California. We also have been able to create a tremendous textbook with Christina Mori and Paul Banwell on the topic of female cosmetic general surgery. I've been doing mostly aesthetic gynecology for the past 30 years, and it's fantastic to be able to share with you what I've learned in regards to pelvic organ prolapse and non-surgical repair. These are some of the doctors I want to credit for helping me in my career and being speakers at my program over a decade ago. There's many here faces that you may know, too many for me to give too much detail, but I want to thank all these people here. Today, we're going to be talking briefly about the science of radiofrequency. This is only about a 10-minute presentation, so this is a clinical primer for you to see the things that we can do with radiofrequency therapies. I'll be talking about cystoceles, incontinence, rectocele, and showing what can be done with radiofrequency treatment. This is the problem of the aging vagina, the dryness, the sagging, incontinence, and prolapse, and that's what we're going to concentrate on. But also the overactive bladder, orgasmic dysfunction, urine infections, vaginitis, and incontinence. This happens as you age and gravity takes over and makes everything fall down. So really briefly, the effects of radiofrequency on tissues result in radiofrequency causing denaturation of collagen, contraction of fibrils, and thickening of tissues. It activates the healing cascade, and new collagen and elastin is formed, new vessels are formed, and nerve fiber density is increased. There's studies that show this, and I'll talk about it really briefly coming up. These are some of the original devices that were used to try to shrink tissues. This is a laparoscopic device to try to shrink the mid-urethra. This was called Surex in about 2002. I was involved in the development of this way back then. It did not succeed in the market, and even vaginal devices like you see here on the right side eventually failed because you needed to actually make incisions to place radiofrequency on the tissues. It wasn't until later that you could use radiofrequency without incisions. This device was placed into the urethra, and these little hooks went into the urethra and caused contraction of fibers for help with stress urinary incontinence. So it did work, but no one wanted to have this painful procedure done every few months, and this failed in the market also because of the invasive nature of having to make incisions, and in this one, having needles that go into the urethra. Pelvic came out in the United States in about 2009. It's a radiofrequency device, so I started using it in 2009 on external vulvar tissues and going inside the vagina as deep as I could. We didn't have a very long probe, so we were limited in how deep we could go. So these are some of the trials I did way back then. And so I started doing some design work on devices that can go deeper in the vagina. The FDA has approved radiofrequency for dermatologic conditions and surgery here in the United States for dermatologic conditions such as loose skin, thin skin, dry vagina, insensitive skin. And the devices can also be used for electrocoagulation, hemostasis, and nerve ablation. In Europe, it's been approved for vulvovaginal laxity to shrink the vaginal and vulvar tissues. This is commonly referred to as vaginal rejuvenation, and I don't like using that term very loosely. Well, this is a landmark study in 2018 by Dr. Banham and Wilson. Monique was one of the fellows that worked through my office, and a study that she did out of Dr. Goldman's office in San Diego revealed a tremendous increase in the thickening of the mucosa, tightening of the tissues, increase in collagen and elastin production in these tissues, and also denser stroma. So this was used to tighten the vulva and the vagina. And we noticed that over the years, I've been doing radiofrequency since 2009 and intravaginal since about 2013, 14, and as early as 2009 with a short device. And we noticed that tissues would shrink. And in this particular case, there was also increase in nerve fiber density when you use a 460 kilohertz device. So not only tightening of tissues, but improvement in nerves of treatment in the external tissues and internal tissues, all the way up to the vagina, the vaginal apex. You can see that this device is very small. It's about the size of my finger, and you can go in all the way till about 10 centimeters or longer into the vaginal tissue. So now we had a way to shrink tissues inside the vagina. So I started using this for prolapse and not just for the external appearance that you see here, but I started tightening external skin. I started treating very dry skin and very loose skin, not just externally, but now we started treating deeper inside the vagina for cystoceles that you can see here, for vaginal laxity, and for even rectoceles. Mid-urethral laxity, I concentrated in this area to help with tightening and reduce the symptoms of stress urinary incontinence. It was not a cure, but it was an improvement. When you combine this with biologics such as platelet-rich plasma, you can really support this area and reduce much of the accidents. So this is the treatments I started using. I started treating on the outside, and you can see how after one treatment, you tighten the tissues on the outside, and after 3 treatments, it was pretty dramatic. So I tried this on internal tissues, and you can see here the tightening of the bulges on the mid-urethra. This lady had stress urinary incontinence and overactive bladder and atrophy also. And so once I treated this mid-urethra, it tightened it up. And you can see here, it's smaller, it's tighter, and now producing more moisture with radiofrequency treatments. Here's another example of some hymeneal remnants and tissues on the inside that we were able to shrink over several months, so that the tissues were shrinking in the inside too. And so we thought, why don't we try this for up to moderate, maybe even severe prolapse. So I tried it on rectoceles and cystoceles. And you can see here one patient that we treated. This happened to be a physician. And after just one treatment, we were able to reduce the diameter of the introitus and also tighten the tissues. And after multiple treatments, you can see another patient here with a cystocele and rectocele right to the introitus. This is stage 2. And when she's standing up, almost a stage 3. We were able to shrink these tissues down with radiofrequency treatments. It took about 1 treatment a month for 3 months to reduce it dramatically enough to reduce symptoms. And your goal is to reduce symptoms. Your goal is not to get rid of the prolapse completely, because radiofrequency or lasers or the combination of both will not be able to do that. Here's another patient that we were able to shrink the tissues. Here on top is before surgery. She's atrophic. Before surgery on the left, on the middle, she was bearing down and pushing, and maximum Valsalva on the right. So we were going to do surgery on her, but she decided instead a trial of radiofrequency. So in 20, treated her with radiofrequency therapies, and over time you can see the reduction in the bulge. Even at maximum Valsalva, we were able to get the rugation back and reduce the bulges. Here's another example, 2015, same patient, 2016, and I did 3 treatments in 2015, and then once a year for touch-ups. 2016 was here, 2017. You can see the tissues continually shrinking down. In 2018, the prolapse was almost gone for this cystocele. It was pretty dramatic. Here's a series of the patients from 2015 all the way down to 2018. So it can be pretty dramatic. Here's a mid-urethra where we did the same thing. We treated the mid-urethra, and you can see it shrinking down and reducing her symptoms of urinary incontinence. Another example of just concentrating on the mid-urethra here and here. So we're able to help the stress urinary incontinence symptoms. There's also some promise with transanal treatments. You can perhaps reduce fecal incontinence and help the reduction of rectoceles by treating transvaginally and transanal. So there's some promise to this, and more studies are ongoing. Also coming up are high intensity focused electromagnetic therapy, or it's called EMSELA in the United States. We combine this with the radiofrequency therapies to strengthen the muscles, reduce incontinence, improve the pelvic floor. This is just like pelvic floor physical therapy using electromagnetic device. And you can see how you can tighten these tissues. And in Italy, the studies have been done by my friend Claudio Catalano, and he has had a good series of pelvic organ prolapse repair. You can see here how before the pelvic floor is down here, hanging down, and after treatments, how it's thickened up and strengthened. So I'm going to go really quickly and show you how the radiofrequency treatment is done. This is the radio frequency device. We set it up to reach around 40 degrees, 45 degrees. Here's the handpiece. We do treat the external for improvement of appearance, especially in older patients. This is a young patient. We then treat internally all the way to the apex of the vagina, about 10 minutes internal for an anterior compartment defect and about 10 minutes for a posterior compartment. And then we're also able to treat transanally for those with fecal incontinence, and also to help reduce the rectocele in some of these patients. So that may help reduce it. And then at the same time, we do those once a month for 3 months. And we can also do the O shots. You can put PRP in the mid-urethra and into the clitoral region for improvement in sensitivity, and sometimes in the introitus if they have, for example, lichen sclerosis. And this may help their conditions for orgasmic dysfunction and pain. So those are some of the treatments we do. The treatments average major 8 to 10 minutes, anterior compartment up to 10 minutes, posterior compartment up to 10 minutes. Post-op and pre-op, or pre and post-op treatments, we use carboxytherapy to improve the tissues so that the skin will respond very well. So I'm running out of time, so it's a summary time. You can think of radiofrequency as a core technology to reduce pelvic organ prolapse symptoms. And you can use electromagnetic pelvic floor therapy also to try to strengthen the muscles. For this, we use it for mostly stage 1 and 2. Sometimes we use it for stage 3 prolapse, but really it works best for mild to moderate. It's a good non-surgical approach for your patients who don't want surgery. It's a rapidly growing field. It also helps, the same treatment also helps with overactive bladder and atrophy, and it's becoming mainstream in the United States. It's slow, but it's expanding in market share. So thank you very much. I appreciate the time that I'm able to spend with you. Please come visit me in California. Visit my website at alansadinstitute.com. Thank you very much.
Thank you, Mala. Thank you for the effort you have taken, and we really enjoyed both the videos, transvaginal uterine suspension and the non-invasive technique. It was self-explanatory. It was wonderful to listen.
Yeah.
Thank you so much.
Thank you, ma'am. Thank you. Wish he was here to explain everything. It would have been much better.
Thank you so much.
Thank you, madam.
Deepa?
Thank you, Sampath madam. Thank you, Hepsi madam. Dr. Deepa is not available, not able to come, madam. So a small vote of thanks. Heartfelt thanks to all the speakers and audiences.
Stop sharing.
Thank you, Shield Company and Dr. Stalin and Dr. Chitrakala. Thanks all. Thanks. We also thank the Almighty for making this happen. Thank you, madam.
Thank you.
Thank you.
Thank you, Mala. Thank you, Sampath. Thank you, Geeta.
Thank you,
Thank you, everyone.
Thanks for the opportunity.
It was very informative and interesting. Thank you. Thank you so much.
Thanks a lot. See you all, ma'am. Bye. Thank you.
See you all. Thank you, Geeta.